image on the right is basically the electric system and how does it work. So as you can see, remember the SA node or the sinoatrial node is what we call the pacemaker of the heart. Electrical signals travel in a normal functioning heart. They should go from the SA node to the AV or atrioventricular node. Then they go down to the bundle of Higgs and around into the Purkinje fibers. And, that movement of that electricity is what makes the ventricles contract and the blood pump out of the heart. And as you can see, if you learn anatomy, that's why I always tell you to make sure that you work on your anatomy and that you get down your anatomy, because once you have the anatomy and you understand what's happening or how it works, that can definitely help you with knowing, with deductive, with inferring, with using your clinical judgment and your critical thinking to figure out how some conditions work, or if something is not working properly in certain conditions. By critical thinking, you can kind of deduct what interventions to do. I'm going to tell you already, like I said, there's a really bad rain where I am. So if I lose signal, I apologize. We're going to try to go as far as we can, but just in case that I lose, because there's a lot of lightning and a lot of rain. This is basically your normal EKG. As far as I'm concerned, the Nclex has not been asking so much anymore about or give it. They do ask about EKGs, but not necessarily it's going to be a picture. They're probably going to be describing something, and you need to determine whether or not that something is normally suspected or there is damage. Remember that one of the ways, or one of the simple, first, easiest way that we can see a little bit of the function of the heart is the EKG. EKG would be your priority action for chest pain. Any kind of chest pain, the patient comes with a chest pain. Let's rule out first a myocardial infarction. This is a simple nursing intervention that we can do without, even having many times an order. You can, yes, get an order later, but this is something that we can get quickly. It would be good for you guys to know the positioning of the leads. I do not have that prepared, like ready, available now. I just thought about it, but it would be a good idea for you to know where to position those leads, because most of the facilities will want to do a 12-lead ECG, and to have a 12-lead ECG, you need to know where you put those leads. So what are the elements of a normal EKG? Who knows? Or name the elements. As you can see, if you were to look at this EKG, what is this? What is this? What is this?
You're always going to have a peak way before then.
EQRS interval, very good. So if it's normal, so the normal components would be your P wave. What does P wave mean? This is atrial depolarization, basically atrial contraction. When we see this every time that the atria contracts. The next thing you will see, that is the lines that go up and down, that is your QRX complex or your QRX interval. That is the ventricle. That is the ventricular depolarization or the ventricular contraction. Very important, because this is how the questions are asking this now. This is supposed to last 0.12 seconds. And how do we measure that? We can measure that if we take a look at this. We can measure how many of the tiny squares. So when we're reading an electro, you see that there's this big square here that is full of these tiny little squares. Each of these tiny little squares is represents 0.04 seconds. So if I tell you that the QRNs is supposed to measure or supposed to be less than 0.12, how many of those little squares I'm talking about? And it's very simple. All you gotta do is add, right? Add the 0.04 or multiply, and that will tell you a number. Or you can divide. Divide 0.12 times 0.04, and that will leave you 3. What does that mean? This QRS complex should measure from beginning to end less than 3 squares. So let's see, let's talk about the PR interval. So the PR interval would be from like here, the point where the P begins, all the way to right here where the Q begins. So this part is what we call the PR interval. Now, this PR interval is the time between the SA node and the AB node. And it should be between 0.12 to 0.20 seconds. Write this down. So PR interval, because this came out on my Nclex verbatim. They wanted me to select the timing of this PR interval. And then they give you options. It can also come up on your exams now, because like I said, they will give you a picture, but they also really want you to know about this timing, how long it's supposed to last. Why? Because if they describe in a question that is a little longer, or that is a little shorter, or that is absent, then you can also recognize a dysrhythmia, not just by looking at a picture, but by knowing what is actually happening in the heart. So again, PR interval between 0.12 and 0.20 seconds. This is the time between the SA node and the AB node, and how long does it last? Going back, so first is that this little first wave that you see is a P wave. A normal ECG or EKG should have a P wave, a QRS, and then a T wave. So just like this. Now, going back again to the QRS complex, that will say that it should last less than 0.12 seconds. And we talk about how this is ventricular contraction. It goes, or we start to measure from about here, right? Like this little, I can't really, I wish this was like a point. But from around here, where the edge of this thing is, and we're going to measure till about here, till by where this began, right? So this much. And we said that it should be how many squares? The whole interval? Who remembers? I just said it. If you get 0.12 and you divide by 0.04, which is the value of each of those little squares.
3.
3 squares. So if we look at here, then from here to here is about, let's count, 1, 2, 3. Yeah, it's about 3 squares. So that means that this is a normal QRS. It's not widened, it's not shorter. The main concern we have is with standard medications. When you hear about medications causing a widening of the QRS, that's what they mean. It means that that interval stretches, and your QRS, instead of being like this, it kind of opens up like that. I believe I have told you guys before that when this happens, there's very high risk for the patient of developing ventricular dysrhythmias, which we're going to talk about it in a little while. How we have atrial dysrhythmias and ventricular dysrhythmias. So ventriculars, the ones that can be more threatening, the ones that really require your attention. All right. Any questions so far? I'm going to interpret the silence as no. So after this, you have your ST segment. ST segment represents an elevation. When you have, for example, ST segment is right here. ST segment is this. ST segment is this, meaning from where your QRS end and right before your T wave begins. this little line here or this little pause. Where have you heard about ST segments? There's a very particular condition in cardio that would talk about the ST segment being very important to diagnose what?
Hypokalemia, I think. Right?
Myocardial infarction.
Myocardial infarction.
Oh.
Very good. This is the part that when they tell you there is a STEMI, because remember, myocardial infarctions could be N STEMI or non-ST elevation myocardial infarction, and they can be S STEMI, meaning there is an ST elevation. What does that mean? It means that this ST segment, instead of being nice and low the way it's here, you're probably going to see them up here. You're going to see that the QRS ends here, and then boom, the ST segment is elevated up here, higher than the way it's supposed to be down here. Now, it basically means myocardial injury, right? So either acute because of a myocardial infarction or something, a past myocardial infarction, something happened. Every time there's myocardial injury or myocardial damage, you're going to see changes there. And lastly, we have the T. This one's the one that Jose was saying about hyperkalemia. When they talk about a peak T, means that this little mound will be like really, not as a nice little mountain, it will be probably shorter and longer, peaked. Similar to a QRS, just obviously not as big, but it can also be very obvious in a patient who has hyperkalemia. The T represents ventricular repolarization. Repolarization, think R from repolarization or relaxation. This means that the ventricle relaxed. It contracted. Remember, this is contraction. It contracted and pumped the blood out. And here is relaxing. You get this little mount when it relaxes. You could have a T-wave depression also. Instead of being here, nice and mount, you will have it down here, an inversion. That inversion also indicate ischemia, myocardial ischemia. So you are going to see changes in the ST segments and changes on your T-wave as well. Any questions so far? Was that very clear?
Yes.
Yes,
Professor.
Beautiful. Yes. So important here also that during the polarization, the calcium channel will open, and that's what makes the contraction. And that's why we give, remember that we give those medications, calcium channel blockers. When your heart is working a little too much, we give those calcium channel blockers to tell the heart to come down a little bit. And that is why, all right? Let's move on. This was just like a little, like a little introduction, because obviously you need to understand how it works. And once you understand how it works, it's definitely going to help you figure out when it's not working, what to do. So the first thing we're going to talk about is heart failure. I believe we talked about this a couple classes ago, so I'm going to be brief. Basically, what it means is the pump, the heart, the motor, the engine, whatever analogy you want to use, it's not working appropriately. It's not pumping enough blood to supply oxygen to the tissues. I have mentioned before that the brain is one of those organs that very quickly reacts to those changes. When there is a lack of perfusion, when there is a lack of oxygenation, the heart is very sensitive. It will immediately react and activate your sympathetic nervous system. And what is the job of the sympathetic nervous system? It puts us in what type of mode?
Flight response.
Very good. Your fight or flight. So that's why you start seeing things like a fast heart rate, tachypnea, your pupils get dilated because, you are sympathetic. So this is kind of like a chain reaction, right? If the pump is not working, let's pretend the heart is the engine, The blood is the fuel. There's not enough fuel, so the brain will start failing first. Then the kidneys, because remember, the kidneys also receive blood. When there's not enough blood, there's going to be a reduction in urinary output. There's going to be stress in the kidney, and the kidney is going to start secreting renin. We're talking about here in this, so when we're talking about less volume, obviously we're talking about the problem here is bleeding, dehydration, volume depletion. For whatever reason, we don't have enough blood to pump out, or where there's several things that can happen, right? Either it's not enough blood, or the heart is so weak, that is the case of heart failure. The heart is so weak that it's unable, even though enough blood is coming in, the heart cannot pump it out. It doesn't have the strength to move that blood out of the heart into the tissues. Another issue would be the blood pressure, the resistance. Remember, every time that blood, is being pumped, is meeting a resistance. Imagine a hose, right? So there's a hose, you open the hose. If there's not enough water, there's going to be only a little bit of water coming out. Sometimes if you have a hose and there's not enough water coming out, what do? We put our finger. You put your finger right at the edge or right at the end of the hose, then you start seeing, even if there's little blood, or there's little water in this analogy, you will see it kind of shooting out with a lot more force. So that is blood pressure, right? That's why in the case of sepsis and hypotension, we give vasoconstrictor. A vasoconstrictor medication is like putting that pressure on the hose to help pump it a little faster and see if, or a little, not faster, a little stronger, to provide and to help supply the organs with that vital oxygen. What else? So that's talking about causes. Once the RAS is activated because of the secretion of renin, then there's vasoconstriction, aldosterone secretion, and a retention of sodium and water. This is just so you understand more or less what happens in the terms of the pathophysiology. It's not the vital thing. It's not what I really want you to focus on. Remember, as nurses, what we need to focus is recognizing, is this right-sided, left-sided, what are the manifestations, what am I gonna do? So that's why I'm going to move on right here. Remember, right-sided and left-sided heart failure, one turns into the other. Your patients start with right-sided, they're going to end up with left-sided heart failure. This is something that it just evolves. This disease evolves into that. How do we recognize that my patient has right-sided heart failure? Elevated jugular venous pressure is what causes that JVD, or that jugular vein distension. You're going to sit your patient at a neutral position in bed. You're going to ask them to look straight and relaxed, and the jugular veins in their neck are going to be very noticeable. They're going to be huge. So I told you there's dilation. Why? Because, so we talk about how blood is coming in, the heart cannot pump it. So what happens to all that blood that the heart cannot pump out? Where do you think is going to accumulate? Anatomically,
It returns back.
it returns
It returns back.
Very good. It returns back. Where? To the right side, because that's where the blood is coming from, right? It's coming from the right side. So it's going to back up, and it's going to cause, that's why we have that fluid accumulation. It backs up into the tissues. It backs up into the organs. So your client is going to have a big liver, is going to have a big spleen, is going to have that edema. That's why we see those patients that have pedal edema, they have sacral edema, they have peripheral edema because of the fluid backup. The renal function, obviously we mentioned this. There's not enough blood coming into the kidney, and the kidney is going to start decreasing the perfusion. So this is important. Okay, this fact that says here is important, that the decrease of the renal perfusion is while during the day, while the patient is walking around, but at night, there's an increased perfusion, and this is why this patient will have to be wait. You find them that during the day they don't pee at all, and at night they wake up 10 times to go to the bathroom, because then there is increased perfusion while they're laying down. The fluid kind of backs up there, and they have to go 10 times to the bathroom. Obviously, there's going to be weakness and fatigue. On the left side of manifestation, this is, again, where does, I told you guys to remember L for lung, left for lung. So where does the fluid that cannot be pumped through the rest of the body on the left side of the heart will accumulate? Well, the closest organ is the lungs. So this is the patient that will present with respiratory issues like pulmonary edema. Your pink, frothy sputum. They're going to have difficulty breathing. They are going to be unable to tolerate laying down, so orthopnea. That paroxysmal nocturnal dyspnea, that means that the patient lays down and they just suddenly wake up in the middle of the night because they feel like they're choking. They literally cannot lay down. This is the patient that will come and tell you, I haven't been able to sleep. I had to sleep sitting on a chair because I have a hard time breathing at night. Or they tell you that they need to be using 2 to 3 pillows to be able to sleep through the night. Hemoptysis, yes, this is the sputum, right? They're going to cough, and when they cough, it's either pink, the pink tinge is blood, or, it's going to be tinge, red blood tinge. What tinge means that when they cough, the sputum has like little streaks of red blood. Here, what is going to enlarge is the heart, and you're going to hear the famous S3, which is, instead of hearing the lub-dub, you'll hear lub-dub, lub-dub. An extra sound is a big, big sign of heart failure. You can also be, the client can also present with tachycardia. Because remember, one of the very first things the heart does when it goes into that sympathetic response, because there's not enough fluid coming in, is, oh my God, there's not enough. Let me pump faster to see if I can send the same amount of blood out, even though I'm not receiving enough. So tachycardia will be one of those manifestations. They can get nausea, they can get abdominal pain, they can get vomiting. And since there's not enough of that blood being perfused into the organs, then you're going to have decreased peripheral pulses. Obviously, there's going to be hypoxia, delayed capillary refill. It's a little chain of events. Any questions so far regarding heart failure? And please stop me. Okay, so again, heart failure is basically the heart cannot meet the demands for oxygen of the tissue because the pump that is the heart cannot pump adequately, cannot do their function adequately. So we're going, as a consequence, we have fluid overload. It will overload in the peripheral tissues or in the legs. It will overflow in the lungs, depending if it's left-sided or right-sided. When you think about it, congestion is fluid, right? Congestion of the lungs, pulmonary and peripheral congestion. This is a chronic condition, meaning this is not something that happens overnight. So your patient will start presenting with this, and sometimes they have what is called a heart failure exacerbation. That's when they come in with presenting with symptoms. They're at home, they start gaining weight. This is the patient that we need to educate to weigh themselves every day with the same amount of clothes at the same time, because fluctuation in weight could indicate a worsening of this condition or an exacerbation. It could indicate okay, you are retaining fluid. Manifestation of left-sided, difficulty breathing, cough, crackles, pink frothy sputum, difficulty or inability to lay down, the paroxysmal nocturnal dyspnea, which I mentioned, they lay down, then they wake up, short of breath in the middle of the night, low saturation. I think that's about it, right? And the right-sided, we talked about it. Organs are the ones that get big. Hepatomegaly, splenomegaly, ascites, vomiting, nausea, weakness, weight gain, the jugular vein distension, and their CVP, which is the central venous pressure, is going to be elevated. All right. Just so you know, because also important, central venous pressure is elevated in right-sided. Pulmonary artery wedge pressure, or POP. I don't know if we have it here, POP. No, we don't. PAWP, POP, pulmonary artery wedge pressure. The numbers for that, I don't know. I've seen this being asked. So for you POP, your number should be between 4 to 12 millimeters of mercury. For your CVP, or your central venous pressure, your number should be from 1 to 8. So what does it mean to have an elevated CVP? It means that the client has too much fluid, hypervolemia. So it's a manifestation. If they tell you that they have an elevated, as their CVP is 9, what does that mean? They have probably right side heart failure, because high means hypervolemia. So if high is hypervolemia, low means the opposite, right? Hypo, they're bleeding. For you pulmonary artery wedge pressure, if the same thing, if it's high, it's hypervolemia, but the pulmonary artery wedge pressure tells us about the left side of the heart, not the right. So again, CVP is for the right, POP is for the left, but they both mean the same. If they're high, hypervolemia; if they're low, hypovolemia. One is from 1 to 8, the other one is from 4 to 12. Let's keep going. What do we do? Let me see if I have the interventions right here. What's this not moving? Let's see if I have the interventions next. No, I think I have the medications. I don't know where I have the interventions. So I guess with the little bit of that I've told you so far, if I tell you what, as nurses, what do we need to do? What do you think is your priority with these patients?
I'll say number one, semi-fold or high folder position.
Beautiful. What, and what's the reason for that?
Because increase the exchange of gases and promote respiration.
Beautiful. So that means that this is the patient that your ABCs, your airway and your breathing is priority. You need to assess respiratory status, because we said their lungs get flooded. So number one, very good. So we're going to, so as part of the assessment, because sitting them up, that's an intervention. How do we assess, or what are we assessing for?
For blood pressure and respiratory distress.
And how do we assess the respiratory distress? Where's my stethoscope? Stethoscope. And we go and we auscultate the lungs. Does this patient have crackles?
Oh, yeah.
Very good. Can you hear crackles? Crackles is fluid. Are they having difficulty breathing, meaning the respiratory rate? Can you see them with effort? Do they have to stop mid-sentence to catch their breath? All of that is your respiratory assessment, because at this point, and I think this is what you guys are maybe struggling a little bit, you have the knowledge. Now we need to apply and turn that knowledge into action. The reason why we auscultate, the reason that we observe, the reason that we pay attention to how they're breathing is because that is a manifestation. That's how we recognize and learn, and you develop that sharp sense. This is probably the most important thing for you as nurses. This is why I said let's focus on what do we do as nurses. Okay, we auscultate. We make sure if there's crackles or there's wheezing, we're going to determine pulse oximeter. Do they need extra oxygen? Do they need a cannula or a mask? Fowler positions, you said it. For volume. So if we know that this patient, we hear the crackles. They told us that we weighed them, and maybe they told us that they gained 4 pounds since 2 days ago. So what are we going to do in terms of volume? Are we going to give them a bolus? Or
No, we're gonna restrict fluids,
very
right?
good. We gotta restrict, absolutely, because they're already drowning. They already have too much fluid in their body. They also need low, when it comes to the diet,
Sodium.
low sodium, between 2 to 3 grams, because I know ATI loves to ask you about numbers. 2 to 3 grams is the number, or
For heart
2,000
failure patients.
for your heart failure patient, 2 to 3 grams per day, or 2,000. If it's milligrams, it's 2,000, 2 to 3,000. If it's grams, it's 2 to 3 grams. Absolutely need to monitor the weight and report. If you notice that your patient is getting between 2 to 3 pounds in one day, you absolutely need to tell the doctor. Even a pound a pound per day is a significant amount of weight. And then we're going to do our pharmacological therapy, and that's where we are in this slide. I also put here a little picture of how preload and afterload works in case you see this in your exam. What does preload mean? Basically, the volume that is coming into the ventricle from the atria. How much blood is coming? Pre is what's coming in, after is what comes out. And the important thing with afterload, here's where blood pressure comes in. There's a resistance that this left ventricle needs to overcome right here in order to circulate the blood. Remember how we talked about a while ago about the vessels being like pipes, and if your pipe is open, it's going to pass, and the heart is working, it's going to pass nice and smoothly. But if this pipe is small and tight because of elevated blood pressure, it's going to be harder for the ventricle is going to have to work harder to try and to try and move that blood to the pipe. That's the issue of the uncontrolled hypertension. And these clients who do not take care, who don't take their medication, who do not control their blood pressure, they end up with heart failure. Why? Because they're making their heart and their ventricles work extra hard in order to be able to pump the blood. So one of the medications that we use this is no longer, digoxin is no longer like the preferred medication. However, they're still used because, it's cheap, insurance cover it, it's been around for a while, but there's so many other ones. The reason why we learn is because it is still in practice and because we have talked about the narrow therapeutic range. I'm going to go really quick over this one because we did talk about this before. It's an inotrope, meaning, what does the inotrope do? Remember what
I think it's strength and contractions, I think.
Strength, very good. So when you think of inotrope, think of muscles. I don't know, the strength of the contraction.
I mean, I learned the opposite, which is chronotropic, chronos, time. So by learning that chronotropic is time, the other one is
the strength. Very good.
Exactly, by remaining the strength.
Very good. So, you're learning, however, it's definitely, yes, chronos is time. So chronos control the rhythm and the rate. Not the rhythm, I'm sorry, the rate. Ino is the strength. So digoxin is part of a family of medications called cardiac glyphosate. The other name that you're going to find there will be lanoxin. Inotropic process, chronotropic negative, increase the calcium in the myocardial cells, has narrow therapeutic range, which is why we need to measure. We need to have laboratory results. We need to take or measure the levels of digoxin in the blood. So our client doesn't have toxicity. Toxicity is the main concern. And how do we know that a patient has toxicity?
GI.
GI disturbances. Very good. What kind of GI disturbances?
Vomiting.
Nausea, yeah,
Yep.
dizziness, vomiting.
What else? One of the first things that the patient might come and tell you, you come in with your lunch tray. What are they going to tell me?
That they have no appetite.
Very good. Anorexia. They don't want to eat. They feel, yeah, like they're just not hungry. They don't want to eat. What else? Yeah, remember that there's visual disturbances. Usually those come about when the toxicity is about, too high. Now, what are the levels?
10 to 20. 20.
No.
You mean the
digoxin?
digoxin?
Digoxin level,
It's
yes.
0.5, I think, to 1.2. It's not too big. It's something small.
Yeah, it's something small.
It's
Similar to
around
that,
those.
yes. Very important to learn. Go ahead. Very important to learn because that's how.
0.5 to 2.
Yes, they're not gonna tell you that the client has toxicity or that the digoxin is high. They're going to give you a number, and you need to recognize whether that number is toxic or not, and how toxic, right? Depending on the level. What else? What else? What else? What else are we missing about digoxin? Oh, okay. So there's a couple of uses. We use this for heart failure, but we also use this for atrial fibrillation. Okay, atrial fibrillation. So if you're writing down, making notes, atrial fibrillation and heart failure. This PowerPoint, I believe I put this PowerPoint in the Moodle room as well. So you can go and retrieve it from there if you want to get information too. Increases the forces of the heart and it slows the conduction rate.
This is for long-term, right, Professor?
Yes, but like I said, it's not the first choice. A lot of cardiologists don't like this in the long term, precisely in the long run, precisely. There's better medications now. There's better medications for dysrhythmia. There's better medications for atrial fibrillation. And, it's also not convenient because if you send your patient with this, you have to be checking the levels, which means your patient will have to constantly be coming in to get that blood work. The precautions. Remember that if you're giving thiazide or loop diuretics, what do they do to your electrolytes?
They reduce sodium and potassium.
Exactly. And the worst one here, the one that we really need to make sure that it doesn't go too low, is the potassium. Some cardiologists, they don't even want it to go below the 3.5. They prefer, they will give you an order, they want to keep it above 4. So if your patient's potassium is 3.8, they will going to prescribe replacement. So you can maintain it above 4. There is, if hypokalemia presents, the toxicity is going to be higher. The risk of toxicity is going to be high. Now, as opposed to hypokalemia, there's also hyperkalemia. If your patient is also taking ACE inhibitors or ARBs, your frills and your sartans, then they have a high risk of the opposite, hyperkalemia. Okay? Then if they've taken, for example, calcium channel blockers like verapamil, that also increased the rates of toxicity. So very, very, very important to write those down because I don't think I put the ACE and the verapamil there. We talk about toxicity. Okay, so yes, first is the GI issues, then is the CNA issues. The CNA issues is not going to probably present as the halos, I see a light. Oh my God, I see a light. No. it presents more as maybe they're feeling tired. They tell you that they don't really want to get up. They will start feeling fatigued. Maybe they will say, I have like blurry vision. I'm seeing double. I don't know what's happening. And then the halos will present. They could be yellow. They could be green. You come into the room and they're like, oh my God, are you an angel? You have a glow. Very important. So what else is important before we give digoxin to a patient?
Check the pulse, apical pulse. Have to be 60 or above. And count for a full minute.
Very good. Great job. What else? What if it's less than 60? And remember, 60 for adult. Go ahead.
You hold the medication.
Very good.
Right.
I'm gonna give you numbers because ATI loves numbers. If it's an adult, it's less than 60. If it's an infant, you know what an infant is?
100 to 140 as a range, or 90 to 140.
Yes, but the range, because remember, kids can also have heart failure. So if your kid is has, what I'm trying to say is, when do we hold? So in an adult, if the heart rate is less than 60. In a child, if the heart rate is less than 70. In an infant is a newborn baby, because again, newborn babies can also have heart failure, congenital heart failure. The number there is 90, less than 90. Obviously, because we know that the heart rate, what's normal for an adult, is not the same for a child. Not sure if they would ask you about children in this time around, but probably for the next comprehensive, because I believe maternity is included there. All right, so what is the numbers? 64, less than 64?
Adults.
Less than 74?
Childs.
Less than 94?
Newborns.
Newborns or infants. Remember, your infant is the baby that's between 0 to 3 months. Okay? Good job. So obviously monitor for signs of toxicity, monitor your electrolytes, monitor your potassium, monitor your magnesium. We're gonna let the provider know if all of the sudden the patient is developing tachycardias, or if the patient is developing any of these manifestations. You also need to let the provider know if you are holding the dose of digoxin. If you don't give the medication to the patient, you need to let the provider know, and you need to tell them why. How do we manage this? So if, let's say, oh my God, yeah, my patient has all these symptoms and the level is 2.1. We run it and it's 2.1. What do we do? What is the first intervention, guys?
Okay, in case of it is above the expected range, you say?
Yes. So
in case of toxicity,
so your patient
hold the medication,
has,
right?
Oh, we give the antidote.
What is your antidote?
Isn't the same?
VG? It's almost the same name.
VGG,
Almost.
ABG.
You got it.
Immune fab.
It's immune fab digoxin, yeah.
Digivine, or any other potassium wasting medication, like insulin, like diuretics. Remember, we talked about how diuretics deplete diuretics deplete our electrolytes. So you can give potassium wasting medications. What else are we going to do? Very important that the Digivine we give only if the toxicity is severe. Before you give that, you can give those other potassium wasting medications before. So if your patient has these arrhythmias, because this can happen in this case as well. So we're going to treat, depending on what the dysrhythmia is, you can give lidocaine. Write it down. For dysrhythmias, you can give lidocaine. You could also give phenytoin. If your client has a bradycardia, what medication have you guys learned that treats bradycardias? Who remembers? Sorry, the dog is being really intense. Ignoring him. Which medication we? Yes, very good. Atropine. Atropine. Okay, that's it.
For bradycardia, atropine.
bradycardia.
Oh, epinephrine, no?
Yeah, but in this case, we prefer atropine.
Atropine.
Atropine. Very good. All right. Any questions about digoxin? I think we covered pretty much everything. Right? Any questions before we move into the diuretics?
Oh,
No?
I don't. Yeah.
Okay, beautiful. All right, so diuretics, we know that, as you can see, so going back, the reason we're talking about this is congestive heart failure. What medications we give? We give these glycosides kind of to improve or to strengthen or to increase the force of the myocardium, because we know that there's a failure. Diuretics, because we know there is an excess fluid, we want to help the patient eliminate those fluids. Vasodilators, again, to reduce the afterload, to reduce the pressure, to make sure that the blood flows easily, and beta blockers, which is the ones that tell the heart to calm down a little bit if it's beating too fast. So what do diuretics do? Decrease volume and decrease the venous return. Remember, the problem here is the preload is too high. There's too much of that fluid getting accumulated, coming into the heart. So beta blockers help us reduce that. Therefore, if you reduce that, there's no damage. I don't know if you ever heard when they say you're drinking water out of a water hose. So it's like someone has an open water hose and you're here and you're trying to drink water and you just splatter it. That's what happens to the heart. So obviously, if you reduce that and there's a little less blood coming in, it's going to be easier for the heart. The heart doesn't have to work so hard. I'm sorry. So you're decreasing the workload of the heart. You will reduce, obviously, the pulmonary and the peripheral edema because the patient is going to eliminate all of that extra fluid through the urine. So what is the expected finding here? Or how do we know that this medication is working?
Increase unit output?
Absolutely. Increase urine output. So here is where it's very important that you follow a strict intake and output. You need to know very strictly how much is the patient drinking or how much is coming in terms of IVs and how much is coming out. A strict intake and output need to be monitored. We also talk about electrolytes already. So if your patient is taking or on a Lasix or furosemide, is the same thing, right? Lasix is just a brand name. If they are in furosemide, whether it's a drip or pushes or pill, you need to monitor their electrolytes to make sure that they're not getting depleted. Remember that you have diuretics that are potassium wasting, like your loop diuretics or your thiazide diuretics, that is the hydrochlorothiazide, and your loop is your furosemide.
How about osmotic? Osmotic are not potassium depleted?
No, osmotic, we would only want to give those in the case of cerebral edema, because osmotic diuretics made the peripheral edema worse. So those absolutely not for heart failure. The preferred in this case will be your potassium sparing or potassium wasting. What is the most popular or commonly used potassium sparing diuretic?
Furosemide.
No, potassium
Wait.
sparing. Remember,
Oh,
furosemide?
spironolactone.
Yes.
Spironolactone, yeah.
Yes. Furosemide is wasting. It wasted. Furosemide and the hydrochlorothiazide, those waste the electrolytes. So potassium sparing will save you potassium. That's the patient that you need to say, please be careful with what you eat. Make sure that they're not eating a lot of bananas, a lot of mangoes, any of the tropical fruits. Those are usually really high in potassium. So we advise them not to take those. Definitely should not be using those salt substitutes. Remember, they're potassium based. So because we're going to tell the patient, listen, you need to go on a sodium, you need to reduce sodium. When the patient goes to the supermarket, they start looking around, the doctor told me I cannot have salt, I should reduce my intake of salt. And then they see something that says, oh, salt substitute. I'm gonna buy this because my doctor told me not to use salt. And then they grab that and they take and they start cooking with that. And then all of a sudden they have a dysrhythmia, a cardiac dysrhythmia. And it turns out that they were on a potassium sparing diuretic, and now they come with a potassium of 6.2, 6.3, or who knows what. And it's because they didn't realize that that product contains potassium, the salt substitutes. So it's very, very important to educate our patients on that. We should not be using this. What else in regards to diuretics? What am I missing? I think that's it. Oh, important with furosemide, remember, is ototoxic. If you push that too hard or too fast, not too hard, too fast. So this should not go on a bolus, even if the doctor orders a push. The doctor orders a IV push, you're going to pass that slowly. Right, at least 3 to 5 minutes, and then you're going to flush it with a whole full 10 cc flush. If they're on a drip, remember, same thing. A strict isonos, electrolytes, and diet. Vasodilators, that is your ACE inhibitors. Your Pril family is the preferred system here. What they do is they inhibit that renin-angiotensin-aldosterone system that I told you before that gets activated when there's heart failure. The angiotensin II reduction leads to vasodilation. That leads to decreased workload or afterload. Remember, that's why we also got to control that resistance that the ventricle needs to overcome when the blood comes out. And there's also aldosterone reduction, which leads, remember, the aldosterone comes from the kidneys, that leads to diuresis, and therefore, yes, there's decreased sodium and water and increased potassium. That's why we mentioned that these are the ones that are going to, hold on. These are the ones that are going to increase potassium. Your ACEs and your ARBs as well, but the Prils or ACE are the preferred, ACE inhibitors. This is enalapril. What else? All the Prils.
Lisinopril.
Lisinopril is very, very common. All of the Prils, guys.
Those are the ACE inhibitors, right?
Those, no, the Prils are your, yes, ACE inhibitors. Yes.
Those are the ones that cause edema and cough, right?
This edema, angioedema, especially, remember that consideration is especially for African Americans. They are the group of people that are more likely to develop that. It's like an allergy. It's like an allergy, no, it's an allergy. Angioedema, which is that inflammation on the lips. The more common manifestation would be a cough, but the cough is benign. The problem is when the client develops that angioedema. Remember, these are absolutely contraindicated in which type of patient? There's one group of people that should absolutely not take this.
Oh, yeah. Asthma patients? No?
Asthma patients.
Asthma is for you beta blockers.
Kidneys. No.
It's a female. It's a female that is. Yes.
Oh, pregnant. Yeah.
You know.
Can cross the
Yeah, across the placenta. Yeah, I remember.
Yes, it's teratogenic. So no for pregnant women, absolutely not given to pregnant women. Very good. What other consideration for this? I don't know. I cannot think of anything right now. What else? What else? What else? No. Well, if I think of something else, I'll be. Well, I think I'm elaborating a little more down the line about these medications as well. Oh, okay. So your names, right? Because I think that's what you guys are telling me, that you guys have like weird names. In this case, for ACE inhibitors, they're all captopril, enalapril, lisinopril. The only different ones is that the enalapril, when it's IV, is called enalaprilat. But again, you still will have the pril. And I think there's one that's called fosinopril, something like that. But it's pril. No way to lose that. And your ARBs, because remember here you can also use an ARB vasodilator. When, for example, if your patient comes and tell you, listen, I have too much cough, I cannot take this. So you change them from an ACE inhibitor to an ARB. Not you, I guess the doctor, the provider, or the nurse practitioner will do that. And then you're going to put it in losartan, valsartan, irbesartan, piolasartan, cosesartan, all of that, right? It's the sartan is the ARBs. So if ACE don't work, they cannot tolerate, they move to ARBs. If ARBs don't work, then we go to calcium channel blockers. Adverse effects. We have talked about this 1,000 times. What is the main one?
Is that sumatriptan, I think?
The main side effect are the ACE inhibitors. The main side effect.
Oh, the ACE inhibitors, you said.
Yeah, of this vasodilator medication. What is the adverse effect, or the most important adverse effect?
They constrict I think it's the veins, the
Hypotension?
arteries, and increase the blood pressure.
Hypotension, yeah.
Oh,
no, the opposite.
The opposite.
They
You
don't
can
constrict.
drop the blood pressure too quick soon, right?
Yes, especially when they tell you that it's a new prescription, that the patient is just starting these medications, or when you change the dosage, when you increase
Right,
the
they can
dose.
get very tired too, right?
Yes, it's not safe. They can get very dizzy. They get the orthostatic hypotension. Now remember, vasodilator, ACE inhibitors is a vasodilator. Vasodilator, it dilates. It makes the vessel bigger, not constricted. Dilates. So yes, number one should be that the safety issue when it comes to the dizziness. Obviously, we need, yes. In this case, we're talking about them being used for heart failure. But remember that we also use them for hypertension. We can use this for diabetic nephropathy as well. We can use this on myocardial infarctions, right? In this case, I put them here for heart failure, but just know that this same type of medication is used for other things. We talk about potassium. We talk about angioedema. We talk about that cough that is very annoying. We talk about not being able to use this, especially in the second or third trimester of pregnancy. That consideration is important. It's to second and third trimester. And in the first trimester, it has to be that patient absolutely needs this medication. And, without it, they can have, aneurysms or stroke, because the risk has to be too high. So nursing considerations. Obviously, before you get a vasodilator, what do we do? What is the vital sign that we monitor?
Blood pressure.
Very good. Blood pressure. If you're giving captopril, specifically, 1 hour before meals, to make sure that the food does not interfere with the absorption of the captopril. If your patient develops angioedema, what are you going to do?
Diuretics.
Remember,
No
angioedema.
restriction.
What is angioedema? Angioedema, the thing that affects African
The
Americans,
swelling of the tongue, right? I think.
is a excessive swollen. Let me see if I have a photo of angioedema. It's massive, massive. I don't know. Did I not put a photo of angioedema? Okay, hold on. Let me show you here. Angioedema is a life-threatening angioedema. This is an anaphylaxis, guys.
Oh,
This is
yeah.
a massive allergic reaction. Angioedema, remember, affects particularly people of color. So if your patient develops this, you're going to react the same way that you would react with any other anaphylactic reaction. So you're going to give
Epinephrine,
no,
EpiPen.
your EpiPen, 0.5 of Epi, and then call the provider
and
and call everybody else.
corticosteroids sometimes, right?
Yes. Yeah.
Metipsona.
Methylprednisolone. But the life-saving thing would be the epi, and go and let the provider know. And there also needs to be another intervention, obviously needs to be put in this patient's file, but they are allergic, anaphylactically allergic to ACE inhibitors, and they cannot use these medications anymore. Let's see what else. What else? I think that's about it with this group of medication. Oh, or beta blockers. Can you guys see my screen?
Yes.
Okay, very good. What can you guys remember about beta blockers? We talked about this, guys. About a couple of weeks ago, we talked about this. Remember,
Contradicted in asthma patients.
What do they do?
They can help with the hypertension to slow down their heart rate.
Yes, very good. So I put a little bit right here. Your beta blockers these are your LOL. What they do is basically they make the heart inotropic negative or weak. Your heart is doing too much and it kind of calms it down. So the heart, what they do is they reduce what's called cardiac excitability. They make your heart not so excited and calming down. They help with that. That leads to better cardiac output. It leads to better oxygenation. It lowers the blood pressure. Remember, because it acts in the heart and also in the blood pressure. The main function will be in the heart, but they do also lower the blood pressure. So you also need to monitor the blood pressure with this one. What else? Like I said, remember beta 1 are the ones that work in the heart. Beta 2, you think of one heart, two kidneys. Beta 2 act in the lungs. That's why we don't give this in the asthmatic patient that someone mentioned before. What else? Yeah, decrease adrenergic stimulation, reducing the risk of cardiac arrhythmia and the heart workload. Yes, they also work for certain dysrhythmias, especially the supraventricular tachycardias. Here's another photo representation of the manifestations of left-side heart failure. So please look at it and review it. This is your right side heart failure and the manifestations. We talked about this already. I knew I should move this back there when I was talking about the digoxin, how it's no longer the first line treatment. This is just repeating, right? So we already went through this. Remember, in heart failure, and also to reduce the heart rate in atrial fibrillation or atrial flutter, this is your toxicity level or your therapeutic drug level between 0.2 to 2. Here's your toxicity. All of this we already talked about. Low potassium, increase the toxicity. check your pulse. Here I put 90 in children, 16 adults. I forgot to put the 70. I'm sorry, the 90 is for infants. I need to correct that. It's 70 for children. Check your potassium. We hold it if it's below 3.5. Here are the signs and symptoms. Oops. Oh, God. Very good. The treatment, if the toxicity is not recognized, again, it can cause ventricular fibrillation and become lethal. Your non-set implications, we'll talk about this as well. We'll talk about weight gain, very important. Second line medication for heart failure. This one's you need to use under a more monitored setting. So this is probably going to be used either in a step down unit or an ICU unit. One of the main ones that we use is Umerinol or Primacor. It's a part of a family called phosphodiesterase 3 inhibitor. This is given via IV infusion. Very important because this is given in a micro doses. It's mics. So you need to make sure that you monitor and titrate this very careful. What you want to do is increase the contractility of the heart. Make sure that the heart beats a little better. And they promote vasodilation. They make the vessels go up. This is one of those medications that I think I've talked to you guys in class about them causing, I'm sorry, about having to give them to a central line. So you need a PICC line or you need a CBC. These medications are vesicants. Remember that we talked about vesicant medications. Now, what are the vesicant medications? What does vesicant means?
What?
What does the word vesicant means?
That can easily cause the patient to blister sensitivity in the skin.
Yeah, vesicant it's an irritating medication, basically. Yes, so that's why we need to give this via a central line. We cannot give this to a peripheral line.
Because any other line would cause irritation around the skin and tissues.
Exactly. It will extravasate.
Steven Jones. Yeah, that's right.
Not a not a Steven Johnson's, it would be an extravasation, which is
Right.
that picture that you see that the person has the vessel very red and irritated, and it almost looks like they were burned from the inside. The medication stays inside the blood vessel, but these blood vessels are too thin. So it irritates them and causes inflammation and swelling, but it's inside. The difference with infiltration is, remember, in infiltration, it comes out of the vessel. All right. Extravasation, yes, it comes out of the vessel as well. Extravasation is of a vesicant medication. So if it comes out of the vessel, meaning the catheter pokes through and a vesicant medication starts accumulating, that's an extravasation. If it's not a vesicant, it's an infiltration. If it's a phlebitis, if it stays inside the vessel, but it irritates it, it turns it red. So you will see the way you distinguish is that you will see red stripes like along the vein. It would almost look like if someone were to grab a marker and just draw down that line. What else? This is an inotrope medication. We give it. When do we give these medications? When you try all those other medications, the first line, and none of those works, which is why I said usually this patient is either on a step down or an ICU, because if all those other medications aren't working, the condition's probably worsening and this patient needs a different level of care. When we're giving these medications, we need to make sure that we monitor the heart rate and the blood pressure very carefully. We already talked about how hypotension can represents a high risk for falls. That's a priority. This patient, another reason why we need a different level of care is because this patient needs to be on a cardiac monitor 24/7. The reason why is because milrinone can cause ventricular dysrhythmias. So it helps with one thing, but it puts you more likely of developing something else. And like I said, ventricular dysrhythmias are those that are not life-threatening. This is short term as well. We don't want our patients on these medications for too long, again, because that risk of those ventricular dysrhythmias is very great. So you want to give this for 2, 3, 4 days, and you hope that the patient start responding along with other therapies. Usually, yes, like I said, an ICU setting, sometimes I've seen this being sent, I've sent a patient home with this medication. When a patient is end stage heart failure, meaning that's it, pretty much the only thing that we can do for this heart is a transplant, and they go for palliative of hospice care. So I have sent patients with this medication home in a pump and with instructions to pretty much as soon as they get home, withdraw that medication, stop giving it, and then put the patient in hospice care. What else? So based on what I said, obviously this cannot go by gravity. You absolutely need to use an infusion pump. You need to make sure that you know the kilograms, the weight of the patient in kilograms. Be very, very careful because this is titrated in mics or micrograms, and you need to know exactly how many micrograms. Do not confuse and put the weight in pounds, because then you're given double or triple of that medication. Since this patient is going to have a CVC, obviously we need to monitor and make sure that there's no infection on the central line. We need to change the dressing using a sterile technique, and we need to monitor the weight daily. Another medication that's used in this category as a second line is necitide. This is form of human B type natriuretic peptide, or BMP. If you guys remember labs, one of the labs that is super elevated in your patient with heart failure, when you go and you do
Troponin.
And what else? There's one that troponin will tell you damage to the myocardium, but BMP is very specific to heart failure. When this is elevated, meaning your patient is on exacerbation of heart failure. So this medication is a form, it's like a human form of that natriuretic peptide. We give it IV for those patients that come acutely, they come into the ED because they have manifestation of exacerbation of chronic heart failure. Same intervention, blood pressure. All of this, vasodilate, lower the blood pressure, risk for falling. You need to confirm this medication with another IV and another RN, I'm sorry. You need to, this is a dual sign-in. Make sure that the order matches what you have and what you're running in the pump to prevent errors. Obviously need to use IV pump. You could give boluses of this and you could give an infusion, but the bolus, because sometimes you can give bolus like you push it, not in this case. In this case, if you are going to give a bolus, you use the pump. In my facility, we do not ever give boluses. That might be different depending on where you work. You need to monitor respiratory rate, breathing, especially in heart failure patients. Follow institutional protocols. That's why I put it there, because this is going to be different. Maybe the facility you're in does not allow boluses, again, because you can rapidly lower someone's blood pressure and they can go into cardiac arrest. So we personally do not do it. Headache, dizziness, nausea. Another one very common, more than the necitide, because this is expensive. So not everybody's going to receive that necitide. Dobutamine. Dobutamines or Wotrex. This is more commonly used. Positive inotrope. So again, Remember, the issue in cardiac failure, the heart muscle is not contracting too well. This is going to increase that. This is very common. We put patients on this drip when they come in for cardiogenic shock. You can also use it on septic shock. What you want is to kind of help the heart recover a little bit. And it helps with the perfusion, which is why we put it those patients who have sepsis. This dosage being weight-based applies to all those three medications, miles per kilo per minute. So very important that you verify your order. You're going to start slow at the minimal rate. These are medications that we titrate. So we titrate by 0.25 or 0.025, 0.025 mics. So you're going to start at the lowest, which is 0.5, and then you start going up by that 0.25 or by whatever the doctor orders or whatever the protocol is in your facility. What you need to learn for examine for Nclex purposes is that you start in the lowest dose and then you titrate up. You can dilute this in dextrose or saline, and do not give bolus of dobutamine. Again, hypotension. Dobutamine goes very slow. All right, any questions?
Professor?
Yeah.
Hi, you said the PowerPoint is in Moodle Room?
Yeah, it should be in Moodle Room. I put it there under cardiac, I believe, week 3.
Okay, because I was looking at the med-surg review PowerPoint, and that's not it. So
No. It's a separate that just says you said either cardio or cardiology.
okay, got it. Thank you, Professor.
You're welcome. What else, guys? Did I miss something? Let me think. We talk about ACEs and ARBs. We talk about we didn't talk about calcium channel blockers. Quickly, we talk a little bit. This is your nifedipine, verapamil, your diltiazem, your amlodipine. Those are your calcium channel blockers. Remember that this is what we talk about. They slow or they block the calcium channel. So what they do is as a result, they dilate the arteries. They decrease the blood pressure by that action. We chose this when you already tried your ACEs and ARBs and you were unsuccessful, so you go with this. Again, since the African Americans have that tendency to develop allergies to ACEs and ARBs, more likely they're going to be on a calcium channel blocker instead. Same thing, we use them for hypertension, we use them for angina. For AFib, you could give the diltiazem, and you can also give the verapamil for AFib. There's another name. Let me look for the other name for AFib that I hold on, because I do want you to familiarize with that name. Let me look it up. Hold on. What is the other name? Cardine. There you go. I never know that name. When you hear about, we're going to put the patient in a Cardine drip or in a Cardizem drip, that is your diltiazem. And this will happen to you. Like at the beginning, they're like, I put the patient in a Cardine. I'm like, don't you want to put him like in diltiazem? And they're like, duh. And then I realized that Cardine is the brand name of diltiazem. It's probably not going to come out as Cardine. This is just for practice, because in the hospitals, you will learn that a lot of people just call medications by their brand names rather than the genetics, the way that we learn them. So again, those can be used for AFib as well. Precautions, same thing. Blood pressure. Very good. Blood pressure, safety. If your patient has, very important, if your patient has a heart block, you cannot give this. I think I talked to you guys at the beginning. I told you a story about a patient I had that got intoxicated with calcium channel blockers and all the things that we had to do in order to stabilize that patient. So if your patient already has a heart block or a pacemaker or something that is a condition that lowers their heart rate, this is contraindicated because this is going to make that worse. So do not give it to those patients. Your names, right? So we talk nifedipine, verapamil, diltiazem, which is the same as Cardin or Cardizem, and amlodipine. What else? Oh, very important. These calcium channel blockers, they have a side effect, which sounds paradoxical because you know how heart failure gives them edema. Well, calcium channel blocker gives them edema, peripheral edema. So that is an adverse effect of this medication. They can also get constipation. They can also get reflex tachycardia. That is like how do you call those when you give something and they get the opposite effect?
First effects?
It is adverse, but it has a different name because, you know, you're supposed to give it to kind of calm the harm down a little bit, and then it causes a tachycardia in response. It causes what is called a reflex tachycardia.
Oh, a rebound? No, that's not the rebound, no.
Not the rebound, it's a paradoxical effect. That was the word, paradoxical. It's a paradox. We give them to kind of calm the heart, and instead, you know, it causes a reflex tachycardia. It can also cause constipation. Do not give it to heart failure. We talk about to heart block, right? We talk about heart block. Do not give it in bradycardia. Do not give them with grapefruit, guys. Grapefruit is a bit no because it can give toxicity. And I think that's it. Yeah. So again, this can be given on a drip or peel. Let's talk about angina pectoris. What is angina? And to
pain
in the chest. The main reason for this is atherosclerosis. Atherosclerosis is a blockage or a plaque that forms in the vessels and causes ischemia. I'm going to play this video for you guys so you can see how or what is the pathophysiology, how does atherosclerosis comes to be.
Atherosclerosis is the buildup of fatty deposits, including cholesterol in the walls of arteries. It's a major cause of cardiovascular disease, including stroke and heart attack, and contributes to the death of around 70 million people worldwide every year. This short presentation illustrates the key stages in its development and its main impact on cardiovascular health. Cholesterol is a natural, fat-like substance and is essential to health. However, too much cholesterol in your blood can be harmful. Cholesterol is produced in the liver, but can also be found in certain foods, such as those high in saturated fats. There are many types of cholesterol. The main type involved in atherosclerosis is called LDL-C, or bad cholesterol. Another type of cholesterol, HDL-C, is called good cholesterol. It's important to increase HDL-C as well as reduce LDL-C when treating high cholesterol. A normal artery wall consists of 3 main layers: a thin, smooth layer that lines the inside of the artery to help blood flow, a muscular, elastic layer that helps the artery pulse to push blood around the body, and a tough outer layer to protect the artery. The exact cause of atherosclerosis is not known, but several factors, including smoking, high blood pressure, diabetes, and high cholesterol, are known to damage the smooth lining of the artery and contribute to atherosclerosis. Once this layer is damaged, the bad cholesterol, LDL-C, can get into the wall of the artery. There are 4 key stages in the development of atherosclerosis. The body tries to defend against the invasion of LDL-C into the artery walls by activating specialized cells called macrophages to consume the LDL-C. They become enlarged cholesterol-enriched cells called foam cells that are embedded in the vessel wall. The accumulation of foam cells can be seen by the presence of fatty streaks in the vessel wall. As the fatty streaks grow, the body tries to protect the artery from them by surrounding them in a fibrous capsule. At this stage, the growth is called a plaque. As the plaque gets bigger, the body tries to preserve the blood flow through the artery. The plaque expands into the elastic layer, which stretches in order to keep the opening of the artery the same. If the plaque continues to grow, its expansion will eventually intrude on the inner opening of the vessel, as the elastic layer cannot stretch anymore. This reduces the ability of blood to get through the artery. At this stage, physical symptoms such as angina may appear. Also, over time, calcium may be deposited in the plaque, making it hard and inflexible. This reduces the ability of the artery to expand to increase blood flow when needed, for example during exercise. As the plaque grows into the artery opening, it squeezes the blood through an ever smaller gap. The resulting increase in pressure at the narrowing can damage the capsule covering the plaque, which may then rupture, resulting in a blood clot that can completely block the artery. Depending on the location of the blockage, the consequences, such as stroke or heart attack, may be severe and could be life-threatening. Atherosclerosis is progressive, and it can take many years before symptoms appear. But some people can have no symptoms even with extensive atherosclerosis and are at risk from sudden death. The symptoms depend on the site of the affected artery. In the heart, it can manifest as chest pains, angina. In the brain, as a type of mini-stroke called transient ischemic attacks. And to the legs as a cramp-like condition called intermittent claudication, which can result in amputation of the limb. If a plaque ruptures, the resulting blood clot may block the artery and cause a heart attack or a stroke, which can often be fatal. Atherosclerosis may cause the artery wall to weaken, causing it to bulge under the pressure from the blood. This bulge, called an aneurysm, can rupture, and the resulting bleed, called a hemorrhage, can be fatal. We hope, after this presentation, that you understand how the bad cholesterol LDL-C contributes to cardiovascular disease and atherosclerosis, and what that means for your health. We also hope you appreciate why always taking your medication, as prescribed by your doctor, is so important in maintaining low LDL-C and high HDL-C in order to reduce your cardiovascular risk.
Very good. Right? So here's your angina. You already saw one of the reasons or one of the pathophysiology of angina is, remember your angina can be chronic stable angina, or you could have acute coronary syndrome. You could have, what is the difference between having chronic stable angina? What does that mean? What does stable angina means?
Go away. Oh, wait.
There.
It goes away.
No, yes, you're right.
It doesn't go away, right? Stable.
No, it does. It's stable means that you have it, but the pain goes away, meaning it's not a constant pain. When does the pain go away? Usually when you take your nitro. You are correct. The pain goes away. That's the difference. That's why stable versus unstable. Unstable could also be called pre-infarction, meaning if it does not go away, it means you're having an infarction. Very good. So going back to why this happens, now you just saw it. It's usually the formation of that atherosclerotic plaque. There's the causes ischemia. So the partially obstructed arteries by atherosclerosis, they cannot meet the demand of the heart, and then it hurts because it's dead. And there's also the lactic acid buildup. That's what leads to angina. This angina is reversible. This is when reversible, I'm talking about the stable, either with rest or with nitro. So that's how we know it's stable. The patient, because the manifestation is pretty much the same as if the person's going to have a heart attack. They feel the chest pain, they feel the discomfort, they feel sometimes the pain, substernal, or substernal, right? Like underneath it. They feel it like underneath here, just like a heart attack. They may feel the pain in the arm. They may feel it in the neck. They feel it the shoulder. They feel the back. So much like what they will feel a heart attack. So obviously, that's why it's a priority. We need to determine if a person comes with a chest pain, even if we find out that they're not having, after we do all the roundup, and we diagnose them with angina pectoris, well, obviously it's a red flag that something is happening, that something will happen. Here you can see now what happens with the buildup, a little bit of the plaque. Obviously, we don't want to get to the point of a total blockage, a total thrombus, because that's where it causes the infarction. Infarction, here's the genetic factors, the risk factors, genetics. Males, unfortunately, are at a higher risk of developing this. If you have high cholesterol levels, especially your LDL and your total cholesterol is elevated, you have a higher risk. Smoking would be one of those very, very high in the list. I'm sorry, of your risk factors, and having a sedentary life. Here we talk about what causes angina, or what I will say it exacerbates it, right? What makes it worse. And here's the difference with that stable angina. So the definition of stable angina is the chest discomfort that usually is relieved or gets better by rest. The client sits down, stops what they're doing, and the pain goes away. That is the stable angina. That's how we know the difference between, okay, this is stable, or is this a possible myocardial infarction. If it doesn't get better with rest, it should get better with the nitro. That's why we give the 3 doses. It should get better by the first or second dose. If it doesn't, then we need to make sure that we transport this client to the doctor, because it's probably an MI. What else? The majority of the causes, you can see, we don't know specifically, but the most likely cause of this is the atherosclerotic plaque. Now, what can precipitate anything that increases the demand of oxygen? Why? Because we already said the supply of oxygen to the heart muscle is decreased. So if I do anything that makes my heart work faster, or that demands more oxygen, the pain's going to go away, because I need more oxygen and I don't have enough supply. So what kind of things? Any sort of physical exertion. The patient's doing exercise, the patient's having sex, the patient's going for a walk. Maybe the patient decided to mow the lawn. They went outside in the yard and they started mowing the lawn. Or they're doing any chore, they're fixing their car. Anything that can increase the heart rate is going to cause, or it can cause angina pectoris. Intense emotion. This is the typical, I don't know if you see the novela, and when you see the mom saying, you know, she gets upset with their kids, and then she says, you're going to cause me a heart attack, and they get the chest pain, and it's very likely a real angina that is precipitated by emotion, by either being very upset, or by having anxiety, or by having fear. Another reason why people who get panic attacks or anxiety attacks get chest pains. There's more demand of oxygen and not enough supply. Again, it's also a sympathetic nervous system response. The heart is working a little harder. Temperature extremes important if it's too, especially cold exposure, but this can also happen in the heat. So if they put you in the options, hot or cold, the answer is yes. What happens when it's too cold? The vessels will constrict, so you already have an obstruction. If you constrict that even more, obviously you're making that condition worse. Sometimes it's the opposite. In the heat, remember, everything that's hot or that gets hot gets dilated. There's dilation. What happens with dilation is not that they cannot pass, but remember, there's already an issue of circulation. That blood can pull up. There's a pooling of blood. So that's what exacerbates. We talked about smoking already, secondhand smoke, stimulants like cocaine and amphetamines. So if this person has this type of condition, definitely should not be doing drugs. We need to advise them not to. Or if they have ADHD, we do know that their medication for ADHD can make that worse. So we need to look for alternatives to amphetamines if we have a patient with angina pectoris and ADHD. And we talk about coronary artery narrowing. That's what we've been talking about, right? Your atherosclerosis. Same thing. This is basically the medications and how does the myocardial consumes oxygen. Treatment, very important. Oh, we talk about the manifestations, right? So you know how to recognize pretty much same symptoms as a heart attack. We're going to come with the same thing. We didn't talk about another type of angina, which is the Prince-Middle angina, which is basically is basically like a spasm in the heart. It's not in the heart, in an arteries of the heart. This one can happen even if the patient is not doing exercise. So they're at rest, and then all of a sudden, oh, I got a spasm. But it's also not an infarction. It's kind of transient. Not much you have to do and learn with that one. Any questions before we move on to the treatment? How do you know? How do we, oh, you know what? We didn't talk about what we do. So let's say the patient comes in, they have all this patient, they have the nausea, they have the diaphoresis, they have the pain here, they have anxiety, they cannot breathe. You give them the nitro. 5 minutes later, they're still in pain. What do we do before we give the second one?
We call 911.
We call 911. You give the second one. 5 minutes later, you assess. Still not better. What do? Give one more.
We get third one. We give a third one.
The third one.
Give the third one, and hopefully by then hold on, guys. The computer keeps disconnecting the charger. Hopefully by then, you know, the emergency services, the ambulance is already there if you're not home. If this patient is in the hospital, they're probably going to be in a nitro drip. That's an IV. And then all you got to do is titrate that up or down, depending on what the order is. So if they come into the hospital, we need to figure out, is this an infarction or is this an angina? When they come in, so what is the first thing we're going to do?
Vitals. Or EKG?
Yeah. Yes, EKG. Obviously, yes, vitals. You can kind of do these things at the same time. The patient comes in, you're hooking them up to the monitor and all of that. We're going to see, maybe we can get something in the monitor, but the most important is get it on the EKG. Can we see an ST elevation? Can we see changes on that T-way inversion? Something that tells me that this is an infarction, but keep in mind what we said at the beginning, not all infarctions are going to cause an elevation. So what else do we do?
Oh, the labs, the BMP.
Very good. So the BMP will tell me The BNPs will tell me cardiac, heart failure, chronic. But if it's something acute, which are the ones? Troponins, the troponins. Now, also keep in mind the timing with the troponins, right? If this is acute, you might not see an elevation right now, but it is very important to do the lab. Why? Because we're going to keep repeating. We're going to get troponins maybe every 2 hours. Why? To see the trend. Are they going up? When are they going to peak and where they start going down? Because that's what's going to tell me the timing of the myocardial infarction. And or is this a myocardial infarction or is it not? Is it just angina? So we did the EKG, we did the cardiac enzymes, we do all the biomarkers. You can do a stress. Let's say that, okay, rule out, the patient got better, the pain went away, the EKG was negative, the labs were negative. Now, okay, it seems like it's an angina. Then you can have the patient do a stress test. Basically, you hooked up the patient to the EKG and you're going to stress the heart, looking for what? Trying to induce that pain. Because remember, angina gets precipitated by exercise. So we're going to do a stress test, we're going to stress them out, and that's going to help us diagnose or help us confirm the diagnosis. You can do an echo. Echo, probably during that, depending on how severe is or how, depending on the facility, they might want to try and get to the bottom of it on that same visit. To the echo, they're going in, let's look at the heart, let's see if there's something anatomically. Because remember, the echo, the ECG tells you electricity. The echo tells you the heart in itself. How are the valves? Are the valves failing? Is there maybe a regurgitation? Is there maybe a stenosis? How are the ventricles? Does this person have a normal heart size or is it a big heart? What is the ejection fraction? What is that? How much blood are they pumping out? That's usually a percentage. Most people are between 45, 55%. If they are reduced, if they are low, obviously that's not good. That's bad, right? That means their heart is failing. You could also do a cardiac catheterization. If the doctors are unsure, you know what, I don't really like it. Let's take this person to the cath lab. Do a cardiac catheterization and let's see. Let's visualize. We're going in with the little camera and we're going to see if there's a blockage in the air, in the arteries, and how big it is, and see if they need to put on a stent. And I think that's it. Remember, when the person comes in and you do your assessment of the pain, because you do have to, again, this is a pain, chest pain, you need to assess. Remember all cards. Onset, when did it start? Location, where does it hurt? Duration, how long? Is this constant? Does this come and go? Does it get better or not? Is there something that make it better? Is there something that make it worse? Of the precipitating factors? What else? I'm missing something else, guys. I said length, duration. Is it radiating? Where does it radiate? How do they describe it? How do they rate it from 0 to 10? So your full pain assessment. Remember to give the medication. So we give aspirin. How much of aspirin? We discussed this, I think, on the very first classes that we have. Aspirin and aspirin. Yeah, aspirin would be, but aspirin, I'm sorry, I don't want to confuse you guys, because aspirin would be if it's an infection. So let's not touch aspirin for now. Let's stay with the angina. So for angina, yes, the treatment is your nitrous or nitroglycerin. The other name that you can find is also sorbite mononitrate. How do you know? Oh my God, they told me it's also sorbite. What is the next word? Look here. It says nitrate. Oh, go back. So it's the same thing. It's a nitrate. It's nitro. So if they give you some weird name that you don't recognize, but you have this suffix, nitrate, is a nitroglycerin. Don't freak out. They vasodilate, reduce the workload and the need for oxygen. This is how they work. Again, obviously, if you vasodilate, you reduce the afterload. There's not that much pressure that the blood needs to encounter here. The vessels open, that blood can pass nice and easy. You have your long-acting or rapid-acting, and then you have long-acting, and then you have rapid-acting. Your rapid-acting is the PRN. This is the one that the patient is going to take home, that it is sublingual, that if they get pain, then they're going to take this one. Or you can give it IV. If the patient has a sudden angina attack and they're in the hospital, we can give this IV on a drip as well. We already talked about what we do, what is the procedure. Obviously, we are not going to give this to the patient if your patient already has a low blood pressure. If you go in there and their systolic is less than 90, this is contraindicated. Or if your patient is taking phosphodiesterase inhibitors. Phosphodiesterase inhibitors, which are what? Your phosphodiesterase inhibitors, aka Viagra, sildenafil, tadalafil, vardenafil, avanafil. How do you know? Again, afil, Viagra. If they don't say the word Viagra or sildenafil or tadalafil, they're going to say phosphodiesterase inhibitors, or they're going to say PDE5 inhibitors. Same thing. Same thing. Basically, Viagra. You also have your long-actings. Those will be your PO tablets or the patch. That in the next slide, I show you the patch. We already talked about this in other classes. This is just a review. Again, we're going to give it to prevent. If it's an acute attack, then you need to give the rapid form, either the sublingual or the IV. Remember, neither the patch or the tablet are to give if your patient's telling you that they're having the chest pain right now. Side effects, we talk about this. Headache. Headache is not a reason to suspend it. Or they get really hot. They tell you that they feel really hot in the face. They get flush on the face. That is suspected. Also, doesn't mean that something's bad. Doesn't mean they need to stop the treatment. Risk for falling. We talk about this. Make sure that the client is sitting down or laying down. This patient needs to be on bed rest. This patient cannot be ambulating. Very important, they develop tolerance. So if your patient wear a patch, 12 hours on, 12 hours off. They cannot wear this patch 24 hours. Protect this from the sunlight. Also the pills. So if the patient goes home with sublingual pills, they're going to be given to them in a dark bottle. You need to make sure that you tell the patient to keep them away from the heat and the sunlight, because if not, they're no longer effective. They cannot have this in the garage. They cannot have them and leave them in the car. They need to take them in a cool and dark bottle. That's it. Here it is. This is your long-acting. Like I said, this is not for an acute attack. This is what it will look like. These are your tablets. I guess this is an example of what that could look like. And this is an example of the patch. Remember that I told you that it was like a little paper. This is the paper, and it looks exactly like that. It comes with this little tube, and then the dosage based on your order is going to say, and you just measure. This is measured in inches. Either it's 0.5 or 1 inch or 1.5 inch, depending on what the doctor ordered. And look, as you can see, she's putting it there. Hold on. She's putting it there, and she's putting like some micropore, some tape over it so it doesn't move. This is called nitro paste. So if they order nitro paste from your patient, this is how you need to apply it. Very good. Remember how we apply. Make sure that there's no hair, no irritation, no open skin. We talk about all of this. It says alcohol consumption, obviously no hot tubs, no sauna, nothing that will dilate the vessels. You're already given something to dilate. How do you know that something's dilate the vessels? I just told you. Everything that gets exposed to heat, it will dilate. It become bigger. So nothing that makes the patient hot. We talk about this. Yes, sublingual. So the patient should not be chewing or swallowing this pill. It needs to dissolve under the tongue or on the side of the cheek between the cheek and the gums. We talk about this airtight dark glass bottle. We talk about rotating the side of the patches. Question. Patient who was walking his dog. Let's see if we wake up because I'm talking too much and I don't hear anyone. Patient who was walking their dog developed chest pain, sat down, and self-administered sublingual nitro. He continues to experience chest pain while sitting down. When should he call 911? Immediately, if the pain becomes more severe. If one sublingual tablet does not relieve the pain after 5 minutes, or if the pain is not relieved after 3 sublingual tablets taken 5 minutes apart.
C. The third one.
D, the
You
last
take
one.
the first one.
C,
No, he would take
C,
the
C.
first
Yeah.
one and wait.
Yeah, so C. If one sublingual tablet
After
does not
the
relieve
5
the pain
minutes.
after 5 minutes, you call him. Remember, before you call 911, no, before you take it, call 911 or at the same time. Boom, boom. You can do both things at the same time. Very good. Good job, guys. Next. Antihyperlipidemics. This is easy. These are medications to lower the cholesterol. Remember, you have 2 different types of fats, cholesterol and triglycerols. Cholesterol travels through the body with the protein molecules called HDL, which is why you want these numbers high. And then you have your LDL. Remember, LDL is the low density, that's the bad one. These are your levels, your normal levels. You want to keep your cholesterol less than 200, your total cholesterol, your LDL or bad cholesterol less than 100, your HDL or good cholesterol 40 or higher. This is different for males and females. Females, the numbers are like from 40 to 45, and triglycerides less than 150. Obviously, because all of this will increase your risk for cardiac disease. I put example of these ones, all the different kinds. You have your statins, fibrates, bile acid binding resids. This the bile acid sequestrant or binding, is that called binding or sequestrants? Sequestrants, think about them, secuestro in Spanish, you like a kidnapping. They're literally kidnapped bile. ATI, for whatever reason, they love to ask about these ones. So look at the names, right? I don't know if you get, I think you guys got asked about the hemfibrocil, or was it the fenofibrate? I don't know, one of these. One of these you guys
It was
were.
the hemfibrocil.
The hemfibrocil, right? On the pharmacology exam. So review this one. Unfortunately, this is about memorization. So for your statins, you know that the name will have the word statin. Those are the easiest ones. Those are the ones that we usually learn. Your possible side effects are here: constipation, diarrhea, stomach, muscle pains. Remember, the most important thing is if they develop muscle pain and weakness, they have the chance of developing of the worst case scenario is rhabdomyolysis. That is an emergency that we need to follow up quickly. We need to give this patient fluid resuscitation because there's damage to the kidney. That is the worst thing that can happen. No grapefruit. Your medications are all the ones that ends with statin: atorvastatin, fluvastatin, lovastatin, rosuvastatin, simvastatin. Your fabrics can give you nausea and stomach ache, fenofibrate, and fibrocil. The sequestrants are the one, like I said, or bile acid binding. They kind of sequester, kidnap fat, and that's the way that they work. They kidnap the fat and we eliminate it. The cholestyramine, the cholesevelam, the cholestipol. A key word when you think about them sequestering or kidnapping cholesterol, fat. So those usually have that word chole, that suffix chole in the name. Just know these medications will help me or will reduce cholesterol. The nicotinic acid, this is just the niacin. I've seen questions about the niacin, and one of the things with niacin is that it causes flushing. So they tell you that the patient's taking it, and then all of a sudden their face is really red and they feel flushed. Doesn't matter. They continue the therapy. This is an expected finding. Ezetimibe, another cholesterol absorption inhibitor. Do you guys heard of there's a pill? There's a pill. It was very famous in the 80s. Gives you diarrhea, but is it O? What's the name of that pill? Oh my God, there was a very famous name. Hold on, I have to look it up. Because if I tell you this name, I know you're gonna know what it is. Setia, but there was another name. Oh my God, hold on. Setia, Rosette, let's say the Setia, but it was very popular. Mm. Oh, I cannot find the name. I cannot find the name, guys. Anywho, so this medication is very good because it will help you lower that cholesterol without, and it has less side effects than your statins. Long-term statins are also not great. Like all medications, right? But you gotta make sure that, again, benefit outweighs the risk. If you have a high cholesterol, you need to take them. You just gotta educate your patient to make sure that they know not to take this. In some cases, people will develop the muscle soreness and they feel really tired, and they they tend to become maybe non-compliant because they know they take this and they feel tired. Tiredness is okay, muscle weakness is okay. When do we start getting worried for possible rhabdomyolysis? If you see changes in the urine, or if this becomes the pain and that weakness becomes severe. The urine is important. If they start seeing the urine turning brown or really, really dark, it's a good idea to go into the doctor. Remember, the best time to take these medications is
morning. No, at night.
At
In the
night.
night.
At night. Very good. What else? Let's see what else we have. The combination of statin and cholesterol absorption inhibitor. This is ezetimibe simvastatin. And then you have a combination of statin and a niacin, which is niacin lovastatin. Who will determine this? The provider, not you. So it doesn't really matter. Most of the patients are going to be on the statins, like I said. Those are the first line treatment. You should probably read a little bit about the other ones, but with the ones that you absolutely need to know are your first line. We'll talk about all of these ones here, the niacin, the biosequestrants, what is cholesterol, what are the types of cholesterol. Remember the HDL and the LDL, what are the good ones, what are the bad ones. Remember the sources of that good cholesterol, because this is what you need to educate your client on. What are the things that they should be consuming? Remember, good oils, avocado, seafood. If sometimes adding that fish oil to the medication regimen is going to help increase that HDL, because remember, the job of the HDL, if we increase it, we are decreasing the LDL. So we want to make sure that the patient has that HDL as high as possible, preferably by improving the diet. Organ meats, animal fats. We mentioned seafood, olives, dairy products. And if they don't have a good diet, which is the case of most Americans, we don't have a good diet, then supplement. Tell the patient to take their fish oil, their omega, right? Omega-3. Here you have again, statins, or if they say HNG-CoA reductase inhibitors, That's basically your anti-lipidemic medication, your statins. Simvastatin, pravastatin. Oh, I put simvastatin twice. I forgot. Atorvastatin, fluvastatin, rosuvastatin. Reduce the LDL and increase the HDL. Take it with an evening meal. Very important. Check the liver function test. Check the ALT. Check the AST. They can cause elevation of those because these get metabolized by the liver. So they can cause drug-induced hepatitis, okay? So very important. Check the LFTs. Myopathy, we mentioned that. Muscle pain and weakness, we monitor, and if it becomes severe with fear and rhabdomyolysis, then we need to take this patient or we need to refer them to the ED. How do we know? You're going to do a blood work, and if they have the CKs or the creatine kinase elevated, usually more 10 times or more than 10 times than normal, then that's an indication of rhabdomyolysis. This enzyme gets elevated when there's massive inflammation in the body. And myoglobinuria, what does that mean? Blood in the urine. That's why I said if you start seeing the urine turns darker, like Coca-Cola color, brown, that's a huge sign the patient needs to go to the emergency room right away. If we said that this medication is hepatotoxic, just someone has a question? I think I heard someone. Is there a question? No?
No.
Okay. Okay, I thought I heard someone. Obviously, if something affects the liver, acetaminophen with caution, or maybe, avoid it. Don't drink alcohol because already you're affecting the liver. Alcohol affects the liver. Grapefruit juice, we mentioned you do not take this with fruit juice, with grapefruit juice. Grapefruit juice potentiates the effects of this, making all those adverse effects even worse. Your fibrates or fibric acid derivatives, which is what you guys got in your exam, gemfibrozil and fenofibrate, they work with triglycerols. So they don't necessarily will lower LDL. What they do is they lower triglycerides. Remember that triglycerides are a huge factor in cardiovascular disease. So the good thing about these medications is that they lower the triglycerides, but they also help you bring up the HDL cholesterol. Again, just like this whole family of medication affect the liver. Check the LFTs. If your patient is taking a statin, so you would say, oh my God, that's good. Maybe take it in combination with the statins. But if the patient is developing adverse effects or toxicity with the statins and they take this, this is going to potentiate or make that toxicity even worse. Again, if they add this, then you have the high risk of developing that myopathy. And same thing with the grapefruit juice. So you're going to learn your fibrates the same way that you learn your statins when it comes to education for the patient and interventions and parameters to monitor. The difference is, what do we use this medication for? Biolicensing questions. This is the ones that I was telling you that they kidnap, they grab the cholesterol and they, they prevent it from being reabsorbed in the small intestine. So they get the bile, and with the bile sequester or kidnap that fat, and then you eliminate it. You do not reabsorb it. Therefore, you are reducing the cholesterol. How do you know? Again, usually they're going to have the word choline from cholesterol, that suffix, cholestyramine, cholesavalent. You can use in combination with statins if you have a person with very, very high levels of cholesterol that, either are not responding too well to the statin therapy, or they're just too high and you want to lower them. They have them extremely high. Now, adverse effect with this, constipation, that's different. If I tell you that this medication sequesters or kidnaps fats. What do you think is going to happen to the vitamins A, D, E, and K? What do we know about those vitamins?
Fat soluble.
Those are fat soluble. So if your patient's taking multivitamins and they're taking this, or even if they're not taking them, this medication can get these vitamins and eliminate them too. It's going to prevent the patient from absorbing these vitamins because these vitamins need fat to be reabsorbed in our body. So this patient is at risk of developing deficiency of vitamin A, D, E, and K. So very important that if the patient is taking this, they probably need to supplement it. Probably the best way for them, since they cannot get reabsorbed by the intestine or by the digestive system, we need to supplement this, and if it's possible, give intramuscularly or IV, because they cannot if they develop a deficiency, they cannot take an oral. It's going to be, this medication is not going to allow them to absorb that. And inactivation of drugs given simultaneously. What does that mean? That if you have to give another medication along with a bile sequestrant and you want the medication to work, you need to give them at least 2 hours apart. You cannot give medications together with this because it's going to prevent them, it's going to block them from the body from absorbing that medication. Your niacin, this is your B3. This is the one I was telling you that produces that flush in the face. That is suspected, that's normal. Niacin is also known as nicotinic acid, also known as vitamin B3. So don't get confused if they learn the 3 names. So if in an exam they say nicotinic acid, you know they're talking about B3. This one also helps with cholesterol triglycerides, helps increase the HDL cholesterol. Like I said, when you take this, there's a release of histamine, so the patient will get flushing. If the flushing is too much, that is causing a lot of adverse effects, or is very annoying for the patient, they really don't want to deal with that flushing and that itchiness that they get, you can give an aspirin. You can give an ASA an hour before you give the niacin to kind of lower that. We talk about the pruritus because, again, the histamine release, and it increased the stomach acid secretion, leading to ulcers. Remember, yes, every time you have histamine release, you can have ulcers. The most important ones, like I said, this I just went over briefly because the most important ones are going to be your statins. Whew. What time is it? All right, just a little a little bit more. Let's see how much do I have. Because, oh, not too much, not too much. Yeah, we're gonna finish that and then we'll be done, guys. Cardiac dysrhythmias. So that basically what we were talking about has to do with the structure of the heart. Now we're going to talk about dysrhythmias, which affect the electrical system of the heart. So there's 2 parts of the heart, the muscle and the electricity. A dysrhythmia happens because there's a disruption. Dysrhythmia or arrhythmia, a disruption in the electrical system of the heart. We talked about at the beginning, the normal pathway will be AV, SA node to AV node, Purkinje fibers, bundle of His and Purkinje fibers. They are the main dysrhythmias that we need to focus on are whether they're shockable or they're not shockable. There are only 4 possible rhythms in a pulseless patient. This is very important. What does that mean? It means that you check the pulse of your patient. There is no pulse. You look into the monitor and you're going to see something. Pulseless patient, shockable rhythm. Those are ventricular tachycardia, ventricular fibrillation, and that's it. That's it. So 4 possible rhythms in a pulseless patient. 2 shockables, 2 non-shockables. Shockable mean that you can put on the defibrillator pads, defibrillate, and attempt to regain normal rhythm. Non-shockable means that you cannot shock them. You need to first get a rhythm before you can attempt to shock. Your non-shockable are your PEA, or pulseless electrical activity, and obviously asystole. There's no rhythm. I put this picture here because there have been questions about, not even about all this. We worried about all of this. In reality, as nurses, what do we do? What is my job? Yes, it's important that you recognize this. So if you come and find your patients in one of this, you know what you can do. But if there's already a recognized dysrhythmia, your job is to place the pads. How do you place the pads? Do you know where they go? So I put these pictures as a reminder. Also important is that when you open up this package, the package has a picture. The things that obviously this is very fast paced, so you're probably not paying attention, but if you forget, there's a picture that is going to tell you. So the way I it's like you're giving yourself a hug. One of the pads go right here. If you think of your apex of your heart, like right here, and the other one goes here. Like you're giving yourself a hug. That's how you're going to put the pad. Sometimes they might want it a little more in the back, but if you're around, doesn't matter if you're over here or more over here, as long as you're here and the other one is here on the chest. That's how you place your pads. Very first thing you need to do, if your patient is on one of these, part of that protocol before we start CPS is make sure that they have the pads and that the pads are connected to the defibrillator or to the portable monitor so you can defibrillate if you have to. So first we're going to talk about shockable rhythms. Like we said, your shockable rhythms are going to be your ventricular tachycardia and your ventricular fibrillation. Your ventricular tachycardia, like I've said over and over and over, ventricular dysrhythmias are the most lethal. These are the most life-threatening. In ventricular tachycardia, the patient's heart rate is going to be anywhere from 100 to 250 to 300 to, you cannot even measure. It's like a super, super fast rhythm. It's very disorganized. As you can see, even though it is disorganized, meaning you cannot really recognize, when you look at this strip, is this a normal strip? No. Can you recognize a P? No. Can you see a T? No. This is just like since it's called ventricular, remember your QRS is the ventricular contraction. All you can see here is ventricular contractions. Are they normal? No. They're wide, they're distorted, some are high, some are low. It's not regular. And this is what you're going to see in the monitor. It's like a little mountain. Sometimes you will see it looking like a little tombstone, and the tombstone is an ominous sign, because if this evolves and you don't do anything, this patient is going to die. So here they're trying to die. If you don't do anything, they will die. So, maybe this is not the perfect tombstone picture, but there's somewhere you can kind of see a little thing like that, and it looks like a tombstone. Rhythm is often regular, but it can be irregular. They are very distorted. The QR complex is obviously, remember that I told you that your QR should be how many squares?
3.
3. Obviously, if we were to look at this is definitely more than 3. Let's take a look at this one. There's 1, 2, 3, 4, 5, 6. Obviously measures more than 0.12 seconds. There is not P, we cannot recognize. Sometimes it's buried, like maybe there you see like a little elevation around here, but that's not a real P. Sometimes you cannot really see it. There's not a visible or noticeable P wave. And obviously you cannot measure a PR if you don't have a P. Pulseless ventricular tachycardia. What does that mean? You come to the room You see this rhythm on the monitor. You go and take a pulse. There's no pulse. What is the first thing you do?
Professor.
Yeah.
I know you said this PowerPoint specifically was on Moodle, but I looked for it and I couldn't find it.
You could not?
No, it's not there. It's not where you said it was in week 3.
Let me see. Because I am pretty sure I put it on. Hold on. I'm almost positive I did. I don't think I have Moodle. Okay, I do. Is this your class? Yes, it is. Oh, it's not there. Where did I put it? Let me double check because I'm almost positive and I put cardiology. It's possible that it's not there. Let me see. If not, I'll make sure to put it on. This one is the EKG. Oh, I don't see it. You are correct. You are correct. So I'll put it on. I'll put it on. I'll upload it after we're done because I will have to close it in order to upload it. But I'll put it on. Wow, I was almost positive. Maybe I put it in the wrong class because I know for a fact I put it on. I put cardiology in big letters. Maybe I put it in the wrong class. All right, where were we? We're almost done. Okay, so very important with this. And, I've had an issue. I had issues with this because whether if you witness or don't witness this, whether the patient has pulse or doesn't have pulse. I have had this rhythm happen with patients very unstable in the ICU, and they're literally talking to you, and you see the VTAC, and they talking, and you're trying to keep a straight face, while at the same time you just slowly back away and go and get the defibrillator, or just go and move toward the defibrillator, because usually if your patient has VTACs, they have to be, at least my patients are connected to the monitor and connected to a defibrillator. They keep their pads on for good luck at all times. So part of those interventions. I've had a patient once had like 90 episodes of VTAC. And we have to shock and shock and shock. So if there is a pulse, you can, again, if they're already connected, you can shock. If they're not connected, then, I'm sorry, if they're not connected, obviously you have to connect them first, then put them into the defibrillator, then defibrillate, and we're going to talk about something important about the defibrillation in the next slide. If there is pulse, you can defibrillate without starting CPR. If there is no pulse in any condition, even if you see a perfect QRS rhythm, a perfect PQRST in the monitor, but there's no pulse, you need to start CPR. CPR, then defibrillation for pulseless ventricular tachycardia. Here's where I think they always get you guys with that. So another one of the shockable rhythms is your ventricular fibrillation. What are you going to see on the ECG? So as you can see, this is a lot more irregular. As you can see this, even though it's definitely not a normal or a typical EKG, it's a little bit more regular. Like you can recognize this shape. It's pretty recognizable. Here, this is just like a disorganization. Do not get confused with like an interference or a malfunctioning when you have this, this is lethal. And I also have a video. So you guys are going to see how one rhythm turns into another one. So this is clearly more disorganized. There's all sorts of different shapes. You can even sometimes get an appropriate rhythm, because at this point, in fibrillation, you know what happens in fibrillation, right? So the muscle of the ventricle is supposed to do this. In fibrillation, it's quivering. So it's like doing this. So there's not really a contraction, an effective contraction. So the main thing that happens is, again, electricity. Usually electricity travels from here to here, from here to here, and then around the heart and causes the contraction. In this case, there's multiple foci. What is a foci? Like a point from where the electricity is coming. So it's like the heart is getting shocks from and signals from a bunch of different points, and the ventricle is doing this. Obviously, there's not going to be effective contraction. There's not enough contraction to propel any blood out to the system. There's not cardiac output. This is lethal, even more lethal. Dead. So if you come in, you're going to have a patient who is unresponsive, who has no pulse, who is apneic. If you do not treat, your patient will die. If you do nothing right away, your patient will die. Who is a high risk for this? A patient who had a recent myocardial infarction, a patient who had a catheterism. So they went in there and they, stimulated, they moved something, they fixed something in the heart. Patients who maybe went in for a balloon pump or for an impella or for one of these procedures in which they actually go in there and they kind of move the ventricle, they do something, and this can happen as a consequence of that irritability or that assault to the heart. Myocardial ischemia, heart failure, and cardiomyopathy. All of these are patients who are at risk of developing this. This can happen while they're putting a pacemaker or while you're pacing a patient. And like I said, it can also happen during or after a catheterization, because again, there was an insult to the heart in those procedures. Someone went in there and messed with it, and that makes it more likely to happen. The very first thing you did here, remember, like I said, every time you have a patient who's unresponsive and pulseless, CPR is your first thing. What is the first thing you need to do? The first thing you need to do is to do CPR. You need to start contractions. Compressions, I'm sorry, contractions. I keep saying contractions. Compressions. You need to do CPR. You need to defibrillate. You need to give medications. What are your medications? They're right there. You're going to give epi. You're going to give vasopressins, and you're going to give amiodarone. All right. Are you guys good on the CPR, or do we need to go over CPR?
I think we're good on that.
Okay, good. So, very good. So initiate CPR, defibrillate, and give medications. As a nurse, you're not going to do everything. Remember, your number one action will be call for help before you start the compressions. You either push the code blue button, or you either go and scream in the hallway, whatever it is, the method that you use, but call for help. Because once you start compressions, once you put hands on your patient, you cannot stop. You need to continue your compressions for 2 minutes straight. Make sure that if your patient have like I said, if your patient have a high risk, they had a procedure, they went to the cath lab, they had an MI, any of these conditions that we just discussed, you need to have next to your bed or in the bedroom. You need to have a defibrillator there. You need to have the pads. You need to have a crash core close back, a crash cart, I'm sorry, crash code, a crash cart nearby, or you need to know where the crash cart is. That's why you call for help, because you're only going to be able to start CPR. And if you're the one in the room, you're the one who needs to start CPR. You do not wait for anyone else. You start CPR, and when someone else comes in, then, they relieve you and you guys can change, and then someone else needs to come and respond and help you bring everything else. What else? So yes, as nursing intervention, make sure that you have everything that you're going to need for this patient in the room. There was something very important. I think I thought I had put it on this PowerPoint. I don't think I put it. Who is going to tell me what is very, very, very important about the defibrillation when we do defibrillation in that VTAC?
Clear the scene.
Like or like make sure it's synchronized or unsynchronized.
There you go. Good. But well, synchronized and non-synchronized, yes. So there are certain dysrhythmias in which you absolutely have to be synchronized, and those are, we're going to talk about those when we go to the supraventricular. I don't even know if I put the supraventricular tachycardia, but supraventricular tachycardia, which is that tachycardia, that very, very fast rhythm, that one needs to be synchronized. Atrial fibrillation needs to be synchronized, and VTAC needs to be synchronized, but it's the VTAC with a pulse, okay? Very important, needs to be synchronized. So when you are putting on the pads, your patient's connected, make sure that you push the button that says sync. So it syncs and it gives the shock when it's supposed to give it. Very good. Non-shockable rhythms, like I said, this will be the rhythms that you cannot shock, because even if you shock, you're not doing anything, they're not going to respond. That is your PEA, or pulseless electrical activity. What is this? You are going to look at the monitor, and the monitor says, you look at the monitor and you see a rhythm, just like this one. You see that very first rhythm. Now let's analyze it. Is there a P wave in the little strip that is there?
Yeah.
Is there a QRS
Slightly.
complex? Yeah, here. There's a P,
Yeah.
and there's a P before every QRS. That's a normal. There's a QRS. You see it right here. Oops, it's not perfect, but there it is. There's one in every beat. Is there a T wave? Yes, one after everyone. So as you can see, it looks like a normal sinus rhythm. Now, what's the difference? You see that on the monitor, but once you touch the patient, what do you think happens with the patient?
It will go crazy, I guess, to get out of the same rhythm.
No, like you come to the room, you see this on the monitor, but then your patient is unresponsive. When you go in there, your patient is not going to have a pulse. Sometimes I sent you guys a video through the WhatsApp group that I hope you guys saw. That is a very good example of how CPR looks like. And at some point, that provider says the patient is on PEA. They don't show it. I don't think they show it on that video, but on PEA means that he's looking at the monitor and he's seeing this, that first strip. He's seeing PQRS, he's seeing electrical activity. But when they do the ultrasound, the heart is on standstill. What does that mean? It's like this, nothing's moving. There's no atria or ventricle moving, nothing. What does that mean? That patient is pretty much dead or dying. Pulseless electrical activity, that's why taking the pulse is so important. Someone needs to always have, when you're doing CPR, someone should always be taking the pulse, either femorally. The preferred in a code is the femoral one, because it's the strongest, but you can take carotid one too. Someone needs to always have that. Why? Also, because how do you measure if the compressions are effective? Because you're going to feel the pulse, you're going to feel the blood pumping. And also because if you just look at the monitor and you see that, you're going to say, oh, perfect, we saved them, and the patient's still unresponsive with no pulse. This doesn't mean that the patient has a pulse. This doesn't mean the heart is functioning. This just means that there's electricity in the heart, but their heart is not responding. So very important. You see this in the monitor without a pulse, you continue CPR. You cannot stop your CPR. You cannot start your compressions. Like I said, you cannot shock that rhythm. You need to continue. You need to give medication until, you in hopes that you elicit a rhythm that you can shock, like a BFID or a beta. Like I said, you will have all electrical activity. It says the ventricular function, BFID or beta, including SR without a pulse. So yeah, if you see this, if you're in a code, you see this, but there's no pulse, you said keep going, continue compressions. And when you look at that video that I sent, you're going to notice that that's exactly what they did. And obviously a systole. Remembering a systole is a flat line. There's not going to be electrical activity. You need to give epinephrine. You can give atropine. You do CPR. You can give pulsing. You can give bicarb. This is up to the doctor. Obviously we're not as nurses, we are not the ones running the code. Or if you have to run a code, usually it would be the charge nurse who will run the code until the provider or the nurse practitioner arrives, and they have to arrive, eventually they will arrive. Because the one that gives these orders would be the provider. You need specialized training for that. All right, this is a ventricular dysrhythmia that is very common. I also have talked about this in the past. It's a premature ventricular contraction. I talk about that this can happen for a variety of reasons. Sometimes if you're dehydrated, if you drink too much coffee, or if you drink too much Red Bull or too much of those energy drinks, you can have premature ventricular contractions. A lot of the times you don't even feel it. Or sometimes it's like you drink your coffee and all of a sudden you feel like you have an extra beat, or you feel like you missed the beat, and you feel like something like a little fluttering in the chest, just on one beat, a quick thing. Other people don't even feel them. This is a benign finding if it's isolated. What does that mean? If you only have one or two, one here and there. The problem is that you have several of these, between 6 to 10 continuous, one after the other one, this will turn into a ventricular dysrhythmia, and then you have an issue. This is basically one time there was a random discharge that came in the ventricle, like some random electrical signal that didn't come from the atria, it just came from the ventricle. Like I said, it can happen at any age in healthy patients. Obviously, if you have a pre-existing condition, like sometimes you will see this in patients who are very elderly, or patients who have heart failure, or patients who had an MI. And after the MI, even if they're stable, you will sporadically see this in the monitor. Like I said, benign, unless they start coming together in groups of 2 or 3 or sustained. Give me 1 second more. All right. So they appear as isolated, random, abnormal, broad, QRS, on an otherwise normal EKG. You can give lidocaine, amiodarone, and drodarone if this becomes, a problem. And I also have a video for you guys to watch. A few words. I really want you to see this one because you can see the progression of it. So these things you see, those are your PVCs, like this random thing. Now here's the problem. This is called bigeminy. Two of them come in at the same time. Now they're coming to close, one after the other. And look at that ST segment up here as well. And look at that. Now what's that? What's that rhythm the patient's on? We just learned it. Very good.
Attack. Yeah.
Yes, very good. That's a VTAC. The patient
So,
went into
Professor, sorry. So before the VTAC, you're always gonna have the primary ventricular contraction.
That's a sign. You could start see them, and you often will see them, and you see one, and then you see another one, and maybe you see two, and then you don't see anymore, and then all of a sudden you see six, and all of a sudden, whoop, you see 1, 2, 3, and then they have what is called sustain. Or what we call them also V runs, in which is this previously is one after the other one. Sometimes a patient will have like 10 seconds of this, and you're like, oh my God, oh my God, oh my God, and then it stops. But you always, if you have sustained more than 6, you should report it to the doctor, just so they're aware that, hey, something's happening because we're getting these V runs. So yeah, usually advances. Now what's happening there? You see the rhythm is changing.
It's going down, right?
Yeah.
No.
And what does this one look like? You see how it's more disorganized?
That is the point.
B-fib?
Yeah.
It's a BFib. It's a beta. It's similar to a torsade. You did see you see the you said torsade point, because it kind of looked like the torsade point that has like a little bow and a disorganized rhythm. But if you can keep going, keep seeing. Fast forward. It does look like a torsade point. But this is a BFib. Remember, we're not doing it. No one did anything. Look at the heart rate. And now this is
Asystole.
asystole, right? Very good. Any questions? Question, guys? No? All right. Very good. So beta blockers. I think this is just going a little bit more in depth of medications that you guys can maybe go in and see, just review it. Calcium channel blockers, we already talked about that. Beta blockers. Again, what are the medications? We talk about the side effects. This is just dividing them a little more because there's different classes. Is there a question? No. Here, your adverse effect of your anti-diuretic medications. Usually, the same medications that we give to control those will give you that prolongation of the QT. Obviously, remember that the risk with this QT prolongation is, like I said, ventricular tachycardias, ventricular dysrhythmias. It can take a person into torsade point. If you use amiodarone for a long time, you can get pulmonary fibrosis. That is one of the most important things. Remember, with fibrosis, it's basically the lung tissue that becomes really, really hard. So this person has a very, very hard time breathing. They have to this gets worse. They have to be intubated. The prognosis is not good if this becomes like a long-term severe problem. So huge with amio would be the pulmonary fibrosis. They can also develop hypothyroidism. With adenosine, can produce prolonged asystole. Now, when it comes to adenosine, let me see if I put the video of the adenosine. Yes, I did.
Professor, which one is the one that does hypothyroidism?
The
Adenosine?
amiodarone.
Oh, the
Amiodarone.
okay.
Amiodarone important fibrosis and hypothyroidism. Now I'm going to show you what an atrial fibrillation is. Remember, so those were ventricular dysrhythmias. I'm sorry. You also have the atrial arrhythmias. Yes, they can be life-threatening. We definitely need to run with those because they have a high risk for blood clots and embolisms. But some people can live with this condition. Like there's people that live with atrial fibrillation all the time. They just have it controlled with medication, but they have a regular life. They go, they drive, they do their groceries, they do everything. The problem here is, well, whether is this an acute thing that just happens and we need to control, or is this a chronic atrial fibrillation? So let me show you guys this video for that. And so, like I said, so if a person can live with this, obviously this isn't as acute and as urgent and life-threatening.
Atrial fibrillation is the most common type of cardiac arrhythmia. In a healthy heart, the sinoatrial node, or SA node, initiates all electrical impulses in the atria. In atrial fibrillation, electrical impulses are initiated randomly from many other sites called ectopic sites in and around the atria, commonly near the roots of the pulmonary veins. These unsynchronized, chaotic electrical signals cause the atria to quiver or fibrillate rather than contract. Although the atrial rate during atrial fibrillation can be extremely high, most of the electrical impulses do not pass through the atrioventricular, the AV node, to the ventricles. This is due to refractory properties of the cells of the AV node. Those that do come through are irregular. Ventricular rate or heart rate is therefore irregular and can range from slow, less than 60, to rapid, more than 100 beats per minute. On an ECG, atrial fibrillation is characterized by absence of P waves and irregular narrow QRS complexes. Reminder: P wave represents electrical activity of the SA node that is now obscured by activities of multiple ectopic sites. The baseline may appear undulating or totally flat depending on the number of ectopic sites in the atria. In general, larger number of ectopic sites results in flatter baseline. As the atria do not function properly, the heart puts out less blood and heart failure may occur. The most common complication of atrial fibrillation, however, is the formation of blood clots in the atria. As the atria do not empty completely into the ventricles, the blood may stagnate inside the atria and blood clots may form. These clots may then pass into the bloodstream, get stuck in small arteries, and block them. When a blood clot blocks an artery in the brain, a stroke may result.
So as I was saying, one of the main risks that we have with atrial fibrillation is the fact that the patient develops clots. So this, and here is a key, this is probably, along with a BFib, the only rhythm that is fully irregular. Again, this is the only rhythm that is fully irregular. So if they're describing something that says irregular, it's probably an atrial fibrillation. Because most of the other dysrhythmias have regularity, meaning their rate is regular. As you can see here in this EKG strip, there's irregularity. You know, this beat comes at a certain rate, and here it takes a little longer, and here a little longer, and here a little shorter. It is irregular. We'll talk about coagulation. So what do we teach our patients? Very important. They need to take their anticoagulation. We need to control certain things with atrial fibrillation. We need to control the rhythm. We need to control we need to put them on anticoagulation. And we need to make sure that we give medications to reduce the ventricular rate. So how do you recognize? I think you saw a little bit of that in the video. There's definitely no P wave. If you look at this EKG, you probably would not be able to recognize a P wave, nowhere, right? You see there's flat, this is flat, it's like a quiver in there, a little quivering, but not a recognizable P the way that you would see it on a regular EKG. So that is your first takeaway if you are analyzing, or if you have to analyze an EKG. Is there a P wave? If it's not, likely it's an atrial fibrillation. Like I said, they're also irregular. And I think that's mostly it. You will have a QRS complex, yes, and you will have a T. The most characteristic thing is no P. The PR interval, obviously, since there's no P, you cannot determine whether or not there's a PR interval. Your QRS, remember they said it was narrow. So if you were to look and count, we talk about QRS being 3 little squares. This only 1 square. There's only 1 square here. Here there's like 1.5. Here is 2. So obviously you're going to have QRS that are less than 3 squares or less than 0.12 seconds. Your ventricular rhythm, this atrial fibrillation, one of the things that can have a very, very fast heart rate. So your patient will tell you that they feel palpitations, their heart rate would be 120, 130, 140. And this one, again, comes from the ventricles, that rate. How do we treat it? Medications, pretty much, is what we can do here. This does not get better with essential oil or alternative treatments, or, this is one of those things in which probably you have to have pharmaceutical treatment. So like I said, we need to do certain things. There are certain goals that we have for treatments. Do you want to decrease the ventricular rate? We want to convert the rhythm, meaning taking out of that AFib and turning back into a normal sinus rhythm. And you need to give anticoagulants to prevent the formation of thrombi, because the blood backs up. Remember, there's not enough perfusion. The blood backs up, it stays in the atrium, and it forms clots. So to decrease the ventricular rate, you can give calcium channel blockers, you can give your beta blockers, and as we talked about at the beginning, you will give your glycoside or your digoxin. Remember, so one thing that all these medications have in common, they're all chronotropic negative. Obviously, if I'm telling you that I want to decrease the rate, we need to give a chronotropic negative. We need to give a medication that slows down how fast this heart is beating. Now, how do we convert them? This is like a chemical cardioversion is what we call. And here you have your amiodarone, because remember that amiodarone is the medication that we use kind of to give like a little restart to the heart, right? Try to get them out of that, dysphrenia back into a normal sinus rhythm. We can also give flecainide. We can also give sotalol. And again, anticoagulant therapy like heparin or warfarin to make sure that they are not, or to minimize the risk of clot formation that can become an embolus and end up in the lung or in the brain. If your client, now, if all these medications are not working and your client is hemodynamically unstable, meaning they have hypotension, then we're going to do electrical cardioversion. Or again, the chemical cardioversion, which is done with your amiodarone. I think I have the next video is the video about the amio. Let's see. No, oh, this is adenosine. Or did I not? No, I don't think I put the amio. It's okay. So you can put them in what is called an amio drip. The amio drip, you will titrate. You can again titrate up or down based on the response. You want to try to make sure that, yes, obviously you monitor the patient's blood pressure, you monitor the heart rate, and this patient probably should be monitored on either ICU or step down unit as well, because you need continuous monitoring. Another one of those atrial or supraventricular dysrhythmias is supraventricular tachycardia. What does supraventricular mean? Supra means above, so above the ventricle, was above the ventricle, your atria. So this is basically just a fancy way to say it's a tachycardia that originates in the atria. The treatment for this is adenosine. This is characterized by fast heart rates of 150 and up. Let me show you what it is and how do we use
It's
adenosine.
currently 1 a.m. and I'm craving Dave's.
Okay. How do we use adenosine to convert that rhythm?
Becoming a nurse is closer than you think. WGU's pre-licensure BSN program combines flexible online.
So look at the rate the person is at. They're beating at 200 beats per minute. Have a heart rate of 200. This patient, they're telling us that has a DKA, severe acidosis, and because of that, they've developed the supraventricular tachycardia. So very important. Here they're showing you there's one IV axis. You need two IV axes. There is the other one. You need at least 6 milligrams per 2 ml of adenosine. If this doesn't work, you can do 12. If that doesn't work, you can start praying.
That's 6 milligrams?
Yep.
And remember, you might feel that funny feeling in your heartbeat discussed once you get the medicine.
So the funny feeling that the nurse is describing is basically their heart will stop. So the funny feeling, the patient will tell you, I'm dying, oh my God, I'm dying, because they would describe as a near death, or they said, I think I died and came back. Well, technically, yes, we are stopping their heart and restarting it with this medication.
Okay?
We'll try to hold that so we don't contaminate it.
Okay. Just make sure we start.
All right, say when.
When?
No.
When?
Now, this is a little unorthodox and unconventional. Do you see how he has two different needles going through the same port? One is the medication, the other one is a flush. Because adenosine has a very short half-life. And when I say very short, I'm talking seconds, which means that you need to give and you need to flush to ensure that that medication gets into the bloodstream.
Sorry.
Okay.
That's okay, you can call your shot.
You want to do it all at once because you want it to get there like a hand grenade. So, not slow, yeah. And what it does is causes a systole and lets your it resets, and hopefully your underlying rate can take back over. And it may not work.
Give it a chance to come back.
I mean, if she's tachycardic like that because it's a cardiac related issue, then it may fix it. But if she's tachycardic because she needs 15 liters of fluid, it may not work.
It worked.
What? Thank you for not being coordinated.
Oh, the funny film.
So now you It'll pass. It'll pass.
So it's what now?
It's about 120 now.
Oh, thank you, Lord.
Uh-huh.
So you could almost hear how the person kind of had a big sigh when the medication went in. And if you were paying attention, you could see in the monitor how it kind of flatlined it for a little bit and then it restarted back into a normal sinus. Like the doctor was saying there, it might not work. Like I say, you can give a second dose or you could double the dose. And, you know, pray that it works. You, depending on the setting, as a nurse, you could give this medication. Some hospitals might want a provider to do it, precisely because you are basically stopping someone's heart and restarting it. So, nursing interventions before I see them, guys might have some questions. As you can see, let's go back and analyze the video. I don't know if at the beginning we could see it, but they have, let's see what the nurse have at bedside. Obviously, this person is connected to a monitor, but she has her two IV access. Preferably, you could have two ports. Look at her right there. This that she has right here, that's an ECG machine. So that patient is also connected to an EKG machine, and she has it on a setting right now in which the EKG strips can come in, continuously, because you want to capture this. One of the things that are important for cardiologists and diagnosing this is to be able to see it on an EKG. So obviously this person needs to be plugged into an EKG. Let's keep going and see what else the nurse have. The fact that he's not wearing gloves is just giving me anxiety, but that might be just me. These are blunt tip needles. He's doing it like this. You could also have two nurses, right? One giving the adenosine and the other one giving the push right after. I guess this technique will definitely ensure that right away, one medication's passed and then the other one, because otherwise, it will take time for you to, remove one and then connect the flush. So this is pretty cool. And the type of needle that he's using is a blunt tip needle, meaning it's not the same one that you use for injections. This is blunt. Sorry, guys, I didn't mean to do that.
Professor, and for example, can it happen that it'll just, because I saw that it happened so quickly, it would just went from 200 to the low 90s and then it went right back up. Could it happen that it goes at a lower pace, or it just goes all the way down?
Yes, it can, and it can happen that the heart just stops. Very good question. Yes, which is why I wanted to keep showing what else is in that room, because again, you're given a medication that's supposed to have a very short acting, so it's going to stop the heart for a little bit, but then the half-life or the half-life is so quickly that it reaches peak and it goes away really quickly. The effect of it passes very quickly. However, it can happen that the heart stays on a standstill, meaning you stop the heart and the rhythm doesn't come back, in which case, obviously, we need to start CPR.
Oh, that's okay.
So keep paying attention to what's around, right? And it happened, like she said, very quickly. This is within seconds.
That's 6 milligrams?
Yep.
And remember, you might feel that funny feeling in your heart be discussed once you get the medicine, okay?
Try to hold that so we don't contaminate it.
Okay. Just make sure it restart.
All right, say when.
When?
Oh,
when.
Ready?
I'm sorry.
Here we go.
That's okay, you can call your shot.
Mm-mm.
You want to do it real all at once because you want it to get there like a hand grenade. So, not.
You see how he said he wanted to get in there like a hand grenade? Pretty much. This works on the SA node, and it pretty much shuts down the SA node.
Slow, yeah. And what it does is causes a systole and lets your it resets, and hopefully your underlying rate can take back over. It may not work.
Give it a chance to come back.
I mean, if she's tachycardic like that because it's a cardiac related issue, then it may fix it. But if she's tachycardic because she needs 15 liters of fluid, it may not work.
It worked.
What? Thank you for not being coordinated.
So I don't know if you guys were able to see the crash cart. So the crash cart should be in the room as well. Everyone should be ready in case that this doesn't work. You can start performing CPR on the patient. An adverse effect of this is chest pain. So we should tell the patient, it's normal that they are going to experience chest pain and shortness of breath after. Again, educate them on what she described as a funny feeling, which is basically, the person we're stopping their heart. So yes, we kind of die for a few seconds there.
Professor?
Yes?
Due to time constraints, I'm gonna have to leave the meeting early. Will the recording be available even after I leave?
It should be, but you guys are telling me that you couldn't access it. Anyway, this will be your last. This is our last. I think there's just one more, and this is, I think that's it. Is it a pacemaker? We just have one more video. So that is about a block, a heart block, but it should be there. I am going to work a little bit on the settings because up until, I don't know, forever, you guys were able to go in the chat and scroll up and the recording was available. I'm going to make sure that I click on the settings to make sure that I enable it for everybody, all right? Thank you for coming in. You guys have been troopers because this is a long time and we still only just cover not even all of cardio, but I hope this was helpful. I don't know. Let's do
Thank you so much, Professor.
You're very welcome. Any questions
it's been
about
very
it?
helpful.
Good. Any more questions about adenosine before we move on?
That's all.
All right, good. Let's do this last one. And blocks is a very, very tested topic. It's very tested in the Nclex too. Oh my God, I hate that I barely touch this and it just goes crazy. So yeah, very, very tested in the Nclex. We're probably not gonna go over all of it, but at another time, hopefully this video, take notes.
Hey, how about you? You want to play me one-on-one? Let's go.
It's currently 1 a.m. and I'm craving Dave's.
10 out of 10.
There are 3 degrees of AV block. First degree AV block, the electrical signals are slowed as they pass from the SA node to the AV node, but all of them eventually reach the ventricle. On an ECG, this is characterized by longer PR interval of more than 5 small squares. First degree AV blocks rarely cause symptoms or problems and generally do not require treatment. Second degree AV blocks are divided further into type 1 and type 2. In type 1, the electrical signals are delayed further and further with each heartbeat until a beat is missing completely. On an ECG, this is seen as progressive prolongation of PR interval followed by a P wave without a QRS complex. This is known as a blocked P wave or a dropped QRS complex. The cycle then restarts over. As this usually repeats in regular cycles, there is a fixed ratio between the number of P waves and the number of QRS complexes per cycle. The number of QRS complexes always equals the number of P waves minus 1. In this example, there are 4 P waves for every 3 QRS complexes. This is a 4 to 3 heart block. Second degree type 1 blocks are usually mild and no specific treatment is indicated. In type 2 second degree blocks, some of the electrical signals do not reach the ventricles. On an ECG, this is seen as intermittent non-conducted P waves. The PR interval, however, remains constant in conducted beats. In majority of cases, the successfully conducted QRS complexes may appear broader than usual. In some type 2 blocks, there is a fixed number of P waves per QRS complex. In this example, there are 3 P waves for every QRS complex, and the condition is described as 3-to-1 heart block. However, as the nature of type 2 block is unstable, this ratio is likely to change over time. Second degree type 2 is less common than second degree type 1, but is much more dangerous as it frequently progresses to complete heart block or cardiac arrest. Implantation of an artificial pacemaker is recommended for treatment of this type of AV blocks. Third degree AV blocks are also referred to as complete heart blocks. In this condition, none of the electrical signals from the atria reach the ventricles. With no input coming from the atria, the ventricles usually try to generate some impulses on their own. This is known as an escape rhythm. On an ECG, 2 independent rhythms can be seen. A regular P wave pattern represents atrial rhythm, and a regular but unusually slow QRS pattern represents the escape rhythm. The PR interval is variable as there is no relationship between the 2 rhythms. Patients with third-degree heart blocks are at high risk of cardiac arrest. They require immediate treatment, cardiac monitoring, and pacemaker implantation.
Very good. So that was an overview of what blocks are. We could go a little more in depth in that and to how to recognize them. There's different mnemonics. Trying to see if I have a good mnemonic or something to send you guys to recognize and learn those. Because yes, these are common on Nclex because they're also common in our patients. Especially the complete heart block of that third degree. The third degree block is the one that is obviously more dangerous. That patient usually should have, if as soon as possible, a pacemaker. If they don't, then an external pacemaker while they await surgery, because they can come with very, very, very low rates. But we will continue. We will elaborate on that probably on Monday, guys. But please keep studying over the weekend. You have a lot of material to review. Keep studying. You have to study hard. I'm going to stop the recording, and then I'm gonna, if you guys have specific questions about the class or something else, okay?